Right, good morning. Good morning, everyone, and welcome to the Adults and Health Committee for our December meeting. I'd like to welcome members of the public and the press who've joined us today, either in the building or online. A reminder, as ever, we allow filming and photography and social media use as long as all of our phones are on silent and vibrate only, and it doesn't disrupt the meeting in any way. We are being live streamed, and a recording of this meeting will also be available to view on the County Council's website. Usual housekeeping points. If you wish to speak, raise your hand. And also for the afternoon session, when we'll have potentially some members and officers attending virtually, you click the raised hand function on Zoom and turn on your camera. In accordance with our constitution, I will briefly adjourn the meeting for a comfort break. If the meeting exceeds 2 hours, it's going to exceed 2 hours. There's no fire alarm test scheduled for today, so if the alarm sounds, I'll adjourn the meeting and we'll all leave via the fire escape, which is situated halfway along the corridor outside this room next to the kitchen, and there are external stairs to the car park and assembly and to the assembly point. Item 1 is apologies for absence. Tamar?
Received apologies from Councillor Ambrose Smith, Councillor Steve Corney, substituted by Councillor Matt Maguire, Councillor Jerry Bird, substituted by Councillor Bryony Goodliff, Councillor Anne Hay. And for the second half of the meeting, I've received apologies from Councillor Liz Every and Councillor Sam Clark, and Councillor Costello will be leaving at 1 o'clock.
Thank you for all of that, and welcome to Councillor Maguire and Councillor Goodliff. You're very welcome. Enjoy the day. Does any member wish to declare any disclosable pecuniary interest or non-statutory disclosable interest? Please.
Just to say that I'm a governor of Cambridge and Peterborough NHS Trust.
Thank you. Yes, please.
I'm reminded, I don't think it's relevant to a particular item, but I'm a governor of Royal Papworth Hospital.
Anybody else? I've got a short announcement. Charlotte Black on my left has announced plans to leave both her current interim role and as Executive Director of Public People Services, and her substantive role as Director of Adult Safeguarding across both councils in mid-January. We fully understand your reasons for doing so. I think there's going to be, I hope there's going to be an opportunity, we've discussed this, for proper tribute to be paid to you then, so I'm not going to say too much now, but I think this will be your last committee. I want to say, as I indeed said at council, that I have been utterly impressed by your professionalism, your commitment, and the care with which you do your work. And you have been an outstanding servant of this council for, I think, 20 years. Through your career, you've come from public health through children's to adults, and now to the second most senior position in the council, and we'll miss you dearly. I have to say that, and I'm very aware that a lot of that time has been under previous administrations, and I'm sure that in saying those words, that I'm saying them not just on behalf of the current administration, but past colleagues from across the political spectrum. So thank you very, very much, Charlotte. We'll miss you. Did you want to add something, Susan?
Thank you so much, Charlotte. And yes, we're going to miss you terribly.
Thank you very much.
Thank you, very appropriately from the Conservative side.
Thank you, Chairman. Can I just say, although I've not been involved with adult services very much, I think I've probably known Charlotte for most of that 20 years she's been here. And I've always been grateful for the advice she's received from her. So I'd just like to say a personal thank you to Charlotte for all that time she's worked with us and the care she's given to us. So thank you very much, Sharon, and enjoy your retirement. I'll put that in inverted commas if there's such a thing. Thank you.
Thank you. I think it is very appropriate, even if I didn't arrange it with you in advance, that we took some time to say that. So thank you for bearing it as well. As was said at full council, Charlotte, as her last substantive piece of work with us, is currently leading work to develop options for both Peterborough City Council and ourselves, Cambridgeshire County Council, to consider our future leadership arrangements for adults, children, education and commissioning, which we intend to be restructuring, and that will be ready for consultation by mid-January. My last announcement is, I'll say more on this in introducing the afternoon session, but we are organising the way we do scrutiny as an experiment this afternoon, having fewer items. We hope, therefore, more chance for interactivity. It's something we've discussed at the spokes meeting with Councillor Bowden too, to try and get more interactivity into it. That feedback's been received, so we'll see how that goes this afternoon. And we also are affected also in our agenda this afternoon by the RCN strike, but I'll say more of that. More on that this afternoon, but there's going to be a few changes in terms of our agenda. Those are my announcements. And any further comment or question? No. So we now move to item 2, which is to approve the minutes of the meeting of the 5th of October as an accurate record, pages 5 to 25 of the agenda pack. Any questions of accuracy? No, I take them as agreed then. Thank you. The action log, as ever, page 27 to 32 of the agenda pack. Anybody want to raise the issue? Councillor Van der Ven.
Thanks. On the Children's Hospital issue, noted and thank you. And it serves as a reminder that we haven't had a meeting with the Children's Hospital for a long, long time. And I wondered if Kate would be so kind as to chase that up. Thanks.
Anyone want to answer that? No, we'll just go in the notes. Thank you. Anything else on the action log? Item 3, we've got no petitions or public questions. So we move on immediately to 4, business planning. We've got Will, Jyoti, sorry, I always have to use second names because of the public access. Sorry about that. Will Patton, Jyoti Atri, Val Thomas and Caroline Townsend, who are here and will be sharing both presentation and answering the questions. The report is on page 33 to 92 of the agenda pack. And going first is Will Patton.
Yeah, thank you, Chair. Good morning, everybody. So, purpose of this report sets out. Is that better? Yeah. Good morning, everyone. So this is an update on business planning. What I propose to do is pull out the key changes from those that we talked about at the last committee. I'll talk a bit about adults and then ask Jyoti to come in and talk about public health. So as we stand corporately, there's a £12.8 million gap. That gap is still being worked on, and actually the size of that gap is yet to be confirmed. Another key change is around the adult social care reforms, which there have been some delays of a minimum of 2 years, but there is funding that's being made available for next year, and but guidelines around that funding have yet to be published. And then the third key element is around the minimum wage, where we had budgeted a number which was 10p an hour off the final minimum wage announcement, which brings in an additional pressure or additional cost into the adult social care budget of 1.5 million. So as we stand today for next year, we've factored in an additional £7.3 million worth of demand for services and a further £14.7 million of inflation, of which 2.7 million of that is supporting the real living wage. We have had already identified £3.6 million worth of savings. They're listed in tables 662 and 663. And since the last committee, we've identified a further £890,000 worth of savings. They're listed in table 665. And they are, I'm pleased to say, further reductions in block cars. So these are the how we deliver home care in cars, and also reviewing when people are discharged from hospital, reviewing those people earlier to make sure that their needs are being appropriately met. We also talk in the paper about further opportunities. I'll just highlight the two main ones. One is around a review of the LDP service, and particularly the contributions that are being made between, and the split of those contributions between health and the local authority. And then the and there is a very, we believe there is a very significant underfunding from health. And then the second key area is about opportunities to support the cost of living pressures. And we're looking at potentially not passing through increases on some services. Let's stop there, Chair, and either hand over to Jyoti for public health or take questions.
I think to Jyoti next. Jyoti, actually, please.
Can you all hear me now? Great. We received an uplift to our grants for 22-23 to the tune of 776,000, which we have used to cover off some inflationary pressures that we had in our stop smoking service and for our health checks, and then to also pay for the Agenda for Change pay increase for our NHS services. And then finally, we've used it to invest in child weight management, which we really didn't have any significant investment in. We don't get our allocation announcement until very late in the year, sometimes early into the next year. So we don't yet know what we're going to receive in terms of a grant allocation for 23-24, which does limit our ability to plan somewhat. Nevertheless, we're making an assumption that that there won't be a cut at the very least to the budget, and that any inflationary pressures will be covered off by an increase in the grant allocation. That is an assumption. We've yet to see that in writing. We have identified a number of small cuts to a range of services that will really have minimal impact, and that is to the value of 61,000, and then some bigger approaches to identifying savings, and that is through the application of a vacancy factor, and then some historical savings that we've made but have not yet been released to our lifestyle contract. And that is to the value of around 220,000. We have yet to also agree and identify exactly what those savings will be put to. One of the proposals is for the savings to pay for the infection prevention control nurse that's currently supporting adult social care. That's paid for at the moment by the CONF grant, which will run out at the end of this financial year. So that's a cost pressure, and that will need to go through a business planning approach before it's agreed. I think the council approach is to ensure that the budget savings are made before any further investments can be committed to. And then the other, any savings that we make still must be spent in accordance with the ring fence conditions of the public health grant. They are still part of the public health grant, and we have yet to identify appropriate areas of public health spend across the council that could be badged against that money. that fulfil the ring fence grant conditions. Thank you.
I think Justine's going to answer questions rather than present. Is that right? Yeah. So is that all the presentations? It is. Councillor, so now the debate and questions. Councillor Van der Ven.
Thank you. I wondered if you could just give us a bit of commentary on the matter of short-term funding, which seems to be a thread in many areas of our work, and the challenge of deploying that short-term funding, both, well, for all the obvious reasons. Thank you.
I'll take a few together rather than one at a time. Councillor Wilson.
Thank you, Chair. I've got a few questions. So if you're taking a few, it mightn't be necessary for Justin or whoever to make a note. On page 44, it talks about the impact of increase in national living wage and real living wage. It would be helpful to understand whether there was a significant difference between them. I think that now that the national living wage has gone up towards the real living wage, there probably is a very marginal change. Secondly, on that same table, it talks about client contributions inflation, and I'd just be interested to know what inflation figure is being assumed for client contributions. On page 91, I think it is, there's reference to charges, and what seems, if I'm reading it correctly, to be quite a significant increase in charges in adults and health. So for example, in 22-23, the charge for setting up the agreement, whatever the agreement is 130, but it's going to go up to 219 in 23-24. Now I may be reading that incorrectly, but that does seem a significant increase, and others on that table go up in a similar amount. Finally, just going back to page 85, it talks about the vacancy rate and does a comparison of, if I can find them. Here we go. On the triple bottom line, accounting for, as an example, mental health section 75 vacancy factor, the social score is 0, the environmental score is 0, and the financial score is 0. To me, that can't be correct, because there must be disadvantages in not having these people appointed. Otherwise, why do we have them on the structure at all? So those are quite a few, I'm afraid, detailed questions. I appreciate there's been a tremendous amount of work gone into all of this, and that's why I'm asking those questions rather than the broader stuff. Thank you.
Good questions. I particularly like the last one. Next, we have Councillor Costello.
Thank you. Under 6.6.3.
Or again, do you mind just putting the microphone towards your mouth a bit? Lovely, thank you.
Okay, thank you. It says savings from decommissioning of a number of discharge block cars as we transition to a new model of delivery. I just wondered what the new model of delivery is.
Thank you very much. And Councillor Murphy.
So I was just looking for the reference. I can't find it just now, but asking about mental health costs and wondering why they are static. Is that just a prediction of what we think we can spend, or is that something to do with demand? I'm just curious.
Did you want, yeah, Councillor Bowden, please.
Thank you very much indeed, Chair. First of all, may I agree with the Director of Public Health about how unhelpful it is to receive information about settlements so late in our budget setting process. And it's not just us, of course, it's around the country. It's nothing new. it's exacerbated, in my opinion, this problem by increasing amounts of individual announcements made at short notice throughout the financial year, which just makes planning even more difficult. And I think it's important to recognise that there is cross-party concern about that as far as this council is concerned. There are two items on the in this agenda item which I'd like to raise my concerns about. The first is the changes on adults and mental health employment support. And we are told within the report that the changes which are being suggested and the continuing expenditure would be spread equitably across the county, is the phrase which is used. But again, we're talking about something which is going to be based in Cambridge City and in Huntingdon. And it seems to me that there is an increasing amount of disparity between the areas where there is spend on mental health in this county and the areas where there is a need. And we are failing, we're not just failing to prioritise those areas where there is the greatest need, we are actively prioritising those areas which have the comparatively least need. We had the case only a meeting or two ago where we were told about the crisis drop-in centres, where in Fenland we get 4 hours a week, Cambridge City gets 25 hours a week. We've got agenda item 9 today we'll be coming to shortly about the accommodation-based support living service for moderate to severe mental health needs, where overwhelmingly it's going to be concentrated in the south of the county and not in the east or the north of the county. And I have severe concerns on mental health that we are almost systematically failing to address the requirements of the area which actually has the greatest amount of mental health requirement, which is Fenland. That's the first point. And the second, on post-hospital discharge reviews, I read that with a great deal of interest. It's an area which I've got a lot of interest in and have followed over many years. It's hardly a new subject and the way in which it's dealt with. And I was pleased to see the proposal, which isn't really spelt out in detail, but we can't see the detail on everything, that £110,000 of investment is proposed in order to achieve recurring savings of 310,000. And this primarily appears to be to do with technology-enabled care and reablement. The principle of that, I fully agree with. I know we haven't been given the detail. The numbers involved surprised me. And the reason they surprised me is, with all due respect, they are so small. And I just wondered if there is the potential to get greater recurring savings by expanding this proposal, and if we can't expand it in 1 year, and I know there are always capacity issues, having a planned expansion of this over the course of a number of years, because as far as I can see, it's a major area for not just potential savings, which is important, but maybe more importantly, for improved care for patients. And ultimately, the NHS should be about, and for that matter, social care should be about the individuals concerned. It's the patients who this is important for, and the use of both reablement and particularly some of the new technology-enabled care opportunities. I just wonder if we are utilising those as fully as we could. Thank you, Chair.
Thank you very much. We did win an award for it, didn't we? So I think we're doing okay, but the question was heard and you'll get a full answer from the officers, I'm sure. I think those are all the contributions. Welcome to Councillor Howell, who has joined the meeting. And I'll just say a couple of things myself. Firstly, adult social care reform may have been postponed, but its consequences are still here with us now in terms of our budget, and in particular, the so-called fair cost of care, which other local councils are calling the cost of care, because there's an absence of fairness in it, has raised expectations amongst providers, both in Cambridgeshire but also elsewhere, which will need managing. And if we haven't got the money because the government gives us it, that's going to be extremely problematic. So that's certainly a pressure on our budget in terms of the next year. I do think, and I hope the officers will also just comment on this in the answers, on the charging points raised by Councillor Wilson, that I think that needs to be read in conjunction with the points elsewhere on the agenda about a review of charging policy. And
my own take, I may be wrong, we'll hear what the officers say, but my own take is that if we're going to increase charges, then self-funders are perhaps less, more able to absorb that than some others, and we have to make difficult choices, but we'll see what our officers say on that. On the mental health employment savings, at first sight, I think they look very hard, but I've been persuaded that that this is an area where we can improve outcomes as well as save relatively small amount of money, but save money. Again, we'll see what the officers say on that, but my antennae are always up when there's a saving by stopping doing something that we're not genuinely cutting. But I think I've been persuaded in this instance. And then again, back to the real living wage issue raised by Councillor Wilson and also Will Patton in his introduction. As is known, I think it's important that we monitor our progressive pathway to full implementation of real living wage with our contractors, and then that must be part of our continuing finance monitoring reporting, and that compliance with real living wage is built into all new contracts. So I think that's really essential. And that just gives us, our officers, an opportunity to reply to that. Will, do you want to start off?
Thank you, Chair. Thank you, Chair. Yes. So I propose I'll answer some and then ask Justine and perhaps Debbie to help comment on some others. So I just want to answer the first question around short-term funding. And I'm sure Justine and Debbie might want to add to this when I hand over. I'd start by saying that any funding is welcome, even short-term funding. We have had short-term funding, and there's been examples certainly over the last few years. And we work with the NHS, for example. So we work collectively across the system to find best ways of using that funding to support our citizens. That said, it is very challenging because from a planning perspective, it makes it very difficult, for example, particularly around workforce, to secure additional workforce on a short-term basis, or to secure additional capacity on a short-term basis is not only difficult, but it also comes typically at a premium price. And so I go back to our preference would always be for long-term funding, because that then allows us to make long-term plans with our workforce, with our providers, with our partners, and actually we can use that money more efficiently as a result. I'll leave Justine to comment on the differences, if I may, between the national living wage, the real living wage, and perhaps some of the charges. We have said in the paper that we recognise the cost of living challenges, and we are reviewing charges, and we'll come back to committee with some proposals on that. As far as the savings from block cars, those savings are, so block cars are, we have had very significant amount of block cars. So these are carers who are in a car and they help, for example, discharge people from hospital and get them home. And we first commissioned those using short-term money. That they are not a particularly efficient way of, for example, discharging people from hospital. And we are, as part of our Care Together programme, so this is about having locally employed carers working with partners, delivering care in the community, we think is a much better model of caring for people, not only in their community, but also discharging people from hospital back into their community. we've had, and this committee approved, a significant investment into our Care Together programme. It's a 4-year programme. And that programme is very much focused on developing that local community capacity. And it's that local community capacity that is helping us reduce the number of block cars that we require. It's a 4-year programme. It's going to take us time. So we will need to continue to commission block cars, but certainly not at the level that we have been. So we think that model is better for carers. It's certainly better for the people that require the support. And it's definitely better for the local authority and the local authority pound, as it were. I'll let Justine or Debbie comment on the mental health employment and the disparity on mental health spend. And then I'm pretty sure Debbie will certainly want to comment on the reablement and tech service.
Justine for the next.
Thank you. So if we start with real living wage and national living wage, it's quite often difficult to compare them because the real living wage gets announced for 22-23, but you don't have to implement it for another 9 months. So they're sort of slightly out of sync. But what we're assuming for next year for national living wage is £10.42 and for real living wage is £10.90. So there is a difference. Those have gone up. National living wage has gone up by 9.7% and real living wage has gone up by 10%. So they tend to move together. I think there will always be a gap probably between them until you get to a point. You know, the minimum wage with the real living wage is calculated in a different way based on how much people need to get by on. So you kind of would expect it to be higher. And we see that you know, the two of them sort of moving together upwards, but always maintaining a gap between them. In terms of client contributions, inflation, that is calculated based on the triple op pension and benefit increases. So as our client contributions towards care are fundamentally driven by benefit levels. So as benefits go up, then client contributions you would expect to go up as well. We are waiting for any definitive announcement on what happens to the minimum income guarantee, which the government sets. And we are assuming that the minimum income guarantee will also move up in line with those pension benefits, but if it does something different, that might affect those numbers going forward. So that's how that's calculated. The increase in charges, I think I might have to come back to you on because I've not been involved in where that comes from. So unless Debbie's got an answer, we might have to come back on that one separately outside the committee. The vacancy rate and the triple bottom line, I suspect the reason it's been done like that is because what we're saying is effectively we're not reducing the service in any way. This proposal is about a one-off reduction because the service cannot recruit those staff at the moment, no matter how hard they try. So I think that's why that's there. It is a one-off and it goes back in again in the following year because the expectation is we would always want to recruit those staff. It's just that the workforce market at the moment is so difficult we can't. Block cars, Will Patton has done. Mental health costs. So I'm assuming that we are looking at the table on page 55. I think what we have got is increasing costs for mental health on 2 of the 3 lines that you're looking at, but not on the top line. And that's really just about how we've allocated inflation at this stage. So we build all our inflation in, we work it across the lines, and it's all on the care packages. Staffing, so the line that says mental health central, which is the one that's not moving upwards, that's fundamentally because that's about staffing, and the staffing inflation is held corporately and given out at such time as the pay awards are settled. So that's why you're seeing that line static. It's not that it's not going up, it's just that at the moment that money for that is being held centrally and will be given out at a later stage, well into 23-24. Probably given that, you know, we've only just settled the 22-23 equivalent. And then I think, Debbie, you can probably answer mental health and hospital discharge.
Please.
Okay, I'm gonna have to move this, otherwise I feel as if I'm talking just to Justine. Okay, so hopefully that will stay there. So first of all, picking up on the increased charges. So we have benchmarked ourselves. So this is charges to self-funders. So we have benchmarked ourselves across other local authorities and also independent providers that support people through this process. So we were quite low in terms of what we were charging. So that's why we've increased the charges. And there was quite a lot of work that sat behind that. In terms of post-hospital reviews, that does look like low numbers, but actually in terms of our reablement services and hospital discharge, on average, we are accepting about 70 people a week. So it varies between 10 and 12 referrals a day. These are people that initially go home with long-term care and support because they're being discharged from hospital much earlier in their pathway. So their needs are quite complex. So the idea behind the post-hospital reviews is for those people that weren't actually ready for reablement on discharge, we go back and we revisit that so that actually we can support people to achieve as much independence as possible. So the numbers are low, but that's because of the high number that we already take through that pathway. But we will continue to review that. So if we feel that we can increase, by increasing our capacity, we can, support more people, we will do that. But this is initial look at to kind of work out what we can do. I think in terms of mental health, I think you covered that off. I take on board in terms of the social score, etc., and the environmental score. So I will go back to a couple of people to say we possibly need to review that. Is there anything I've missed?
Anyone want to come back? I'll just see before I start calling. I want to take two, but then that will be it. Councillor Bowden first.
Thank you. I did make the point that there is a significant disparity in a whole host of areas on mental health between different parts of the county in terms of the amount of provision that there is. And that is unfortunately proportionate to the need, need there is. So the greater, inversely proportional, sorry. So the greater the need that there is, the less funding there is for different areas. And that wasn't covered.
And Councillor Slatter.
Thank you, Chair. Just following up on Councillor Costello's question, I want to hear what the answer was to see if she covered the business of cars. I'm well aware of there's pros and cons on providing cars and how we provide them. I am very keen, though, that we don't make false economies and deter people, because we've had correspondence, I've passed it on to officers about people who were thinking of becoming carers for us, but found that there was an unhelpful bureaucracy involved with insurance for private cars and the allowances for petrol and so on. And going forward, we're going to have to be careful that we make provision for our workforce in the pursuance of the place-based care, which still requires some car traffic. I've tried doing things on a bike, and some things, yes, you cannot do. Just to make sure that we are having an eye to the detail so that we're not in conflict with our own policies. I'm really keen that we should keep an eye on that detail. Thank you.
Okay, fair comment. I don't think that needs answering. But we'll note it in the minutes if we may. But I'm sure everyone would agree with what you said. But on Councillor Bowden's point, Debbie McQuaid.
Okay, so I'm going to have to come back to you in terms of a more detailed response to that. What I can tell you in terms of supported accommodation, so taking on board what you're saying, in terms of where the resources are, where the support is, that is being re-tendered to provide more equitable service across the county. But in terms of providing more detail, yeah, unless Will wants to come back in.
Yeah, so can I propose that we take that question away and then respond?
Of course, you can propose that. We can all agree as well. The only thing I would say, I think around this table, there'd probably be a consensus that the distribution of our services isn't always optimal. And past decisions haven't enabled that. I completely respect Councillor Bowden also for batting for his area, and we all bat for our areas in some respect, but certainly as far as the administration is concerned, what we want to see is an equitable sharing of services to target need where it is, but to make sure that there's
good access to our services throughout the whole of the county, and I'm sure that that is not a controversial sentiment. The other points I'd made, there were people didn't ask about the public health savings and where the money's going, but I just the steer that this committee I think should give to those decisions is that the public health ring fence should be fully respected, and that where savings are able to be made, well done. That's about providing more efficient as well as more effective services. The money should be redistributed based on public health outcomes as the key priority. Though people didn't respond to what Will Patton said about the baseline budget on learning disabilities, you know, I don't know how many people amongst our health partners are watching or listening to this or in hindsight, but just to say, we want to continue a very constructive dialogue with our health partners about this. And there's a lot of flexibility on our side in order to reach a just outcome. So I just want to place that on record. Many of us are saying that privately as well. And I know our officers are as well. So the recommendations are noting the progress made to date, next steps required to develop a business plan for 23 to 28, to comment as we have and endorse the budget savings and proposals that are within the remit of the committee as part of the consideration of the overall business plan, and to note the updates to fees and charges for 23-24. As that is all noting, we don't need to vote on it. So thank you very much to all the officers and in fact all the contributors to that debate. Next, also a very important item in the strategic section of our committee this morning is item 5, Director of Public Health Annual Report. It's found on pages 93 to 106 of the agenda pack, and Jyoti actually will introduce.
Rhiannon, I might need some help with the presentation. It's not showing on my screen. Have you got it?
If everyone just bears with this for a second.
Thank you very much. Thank you. Could you change it to, that's it, brilliant. Thank you. It's a statutory obligation for me to produce an independent annual report. This year I've chosen to focus on inequalities and a bit of a critique on our approaches to addressing inequalities, with some recommendations on how I think we should tackle them moving forward. Could I have the next slide, please? Thank you. So the first thing to point out is that despite decades of us knowing about health inequalities originating in the Black Report in the 80s, numerous other reports, the Marmot Report, the Marmot Follow-up Report, numerous national and local attempts at reducing inequalities, we have failed to reduce inequalities, and in fact they have widened. So that is a shocking state of affairs as far as I'm concerned, and has led to me producing this report to consider why that's happened and what we could do to address it moving forward. Could I have the next slide, please, Tamar? So inequalities are unfair and avoidable differences in health outcomes between individuals and communities. The impact of COVID-19 has really shone a light on inequalities. It's exposed those inequalities that have been with us for many years, and in fact has probably resulted in an exacerbation of inequalities. We know that certain parts of our population were more at risk of acquiring COVID and having worse outcomes. It's widely acknowledged that the determinants of health inequalities lie predominantly in the wider determinants. So, you know, the type of education that you have, the level of education you leave full-time education with, your income, the type of employment you have, where you live, have a much bigger impact on health outcomes than anything that the health service can do. So therefore, any attempts to address health inequalities need to bear that in mind. And if we focus only on people once they've reached the doors of our services, we won't reduce inequalities in health outcomes. There's also a wealth of evidence that demonstrates that intervention earlier in the life course is more effective, more cost effective at reducing inequalities, and will have impact throughout the life course. So if you really want to address inequalities, focus on early years and the wider determinants. Could I have the next slide, please, Tim? There is a natural tendency, I think, to want to focus on the poorest areas in our county, and that's partly because we have data that we analyse by deprivation quintiles, and we present that data, and that kind of leads to the natural conclusion that therefore you need to put your investment into the poorest areas. Completely natural reaction to the data that we present. But just putting the money into the poorest areas alone, without being mindful of the evidence base of effective interventions, won't necessarily lead to a reduction in inequalities in that area. So if I give you an example, if we, Finland has the highest smoking prevalence, if we just put in more money into smoking prevalence in Finland, and yet people don't take up that service, it won't make a difference to smoking prevalence. We need to back it up with other interventions to ensure that uptake actually happens. You know, whilst there may be a higher proportion of people who smoke in Finland, collectively there will be more smokers in the rest of the county. And I'll demonstrate that with a slide in a moment. Furthermore, there are a number of examples of incredibly effective universal interventions that have reduced inequalities. And they are the smoking ban, for example, that has had a disproportionate effect on smoking prevalence in more deprived communities, and fluoridation is another. I recognise those are both national examples, and of course we need to apply that learning to interventions that we can apply locally. Could I have the next slide, please, Tamar? So this is the graph that I referred to earlier. This is showing across the bottom IMD quintiles, and across the side the proportion of individuals that are income deprived within each of those IMD quintiles. What that is showing is that in the most deprived quintile, we have 30% of our overall income deprived individuals, meaning that just under 70% of our income deprived individuals are outside our lowest quintiles. So if we were just to focus our interventions on that lowest quintile, we miss the majority of individuals who could benefit. And even in the wealthiest quintile, we have about 11% of our deprived individuals residing. Could I have the next slide, please? So the other approach to targeting that's often employed is to focus on those individuals deemed to be at highest need. This is showing the distribution curve for overweight and obesity. So if we were just to focus on individuals who are obese, you can see from this graph that we would miss the majority of people in our population who are overweight. We have about 70% of our adult population who are overweight or obese. If we just target those that are obese, and in fact, if we just use the targeted approach per se, we miss a massive opportunity to shift the entire curve of our population. The other kind of critique of targeted approaches is that they often lead to stigmatization and poor uptake. And I can give you an example from a previous job where we had a targeted weight management offer for children who were overweight, and only 5 children took up that service every year. I had a lot more than 5 children who were overweight, I can guarantee. And so that's another example of where targeted approaches may not result in the kind of impact that we would like to see. Can I have the next slide, please, Tamar? So, as I've said, universal approaches, there are a couple of national examples of very effective universal approaches at reducing inequalities. The other really strong argument for a universal measure is to identify individuals in need. So, health visiting is a perfect example of this. We have a universal offer. We visit every child before we visit every mother before the child is born, and then in the first 2 weeks. And that is so important, because if we didn't, how could we identify those individuals who are in need and then needed further help? So universal offers are really important to systematically identify individuals who are in need, who, as I've said earlier, are distributed across our county and not concentrated in any one area. I think there is one potential downfall of a universal approach, and that is, I've seen a number of universal approaches that have materially improved outcomes across the spectrum, so in deprived communities and in more affluent communities, but they may not reduce inequalities. Now, that's an ethical consideration, I think, for us. My personal view is, if we save lives in those poorest communities, surely that's something we have to go for, even if it doesn't reduce inequalities. Could I have the next slide, please, Tamar? So in conclusion, I think we need to focus on universal interventions first and foremost, and then we need to supplement that by a systematic approach to identifying individuals who are in need. And I can give an example of that. We are currently working on a pilot to support women who smoke in pregnancy. What we're doing is systematically identifying individuals who smoke in pregnancy. Often there's stigma to smoking in pregnancy, and women won't admit to it. But if we carbon monoxide test all pregnant women, we can systematically identify those who themselves smoke or are exposed in their households to tobacco, and then offer them an intervention. And we are currently piloting incentives to support those women to sustain their cessation throughout their pregnancy, and that is there is an evidence base for that approach. Whereas, as opposed to just perhaps putting a pilot into Finland, where we've got higher smoking in pregnancy prevalence, and then missing a number of individuals across the county who could benefit. So yeah, and then the other recommendation is that we focus on more upstream, wider determinants type interventions, and earlier in the life course, if we really want to impact on health inequalities and outcomes in health inequalities. Where we do target, it needs to be through the systematic identification of individuals in need, and interventions should be evidence-led. And then to supplement our interventions through behavioural insights to really understand inequalities in behavioural risk factors and inequalities in uptake to services, and then address those according to what the insights actually identify to us. Thank you.
Thank you. And you're asking some very challenging questions, not just informing our own public health programmes, but also in dialogue with our health partners, and very proper role of the Director of Public Health. So I congratulate you on that, and I'm sure there's going to be an interesting debate now within this committee. Councillor Gordon, please.
Yeah, thank you. Thank you so much for such a bold and honest and independent report. I guess it's still in draft because we have to accept it. The title, to be fair, captures the spirit of what you presented to us. I guess from a personal point of view, I would say I've been a councillor for a long time and on versions of this committee, and we have always very compellingly taken, I think, a targeted geographic approach. And what you're saying in this paper is very worrying, that this doesn't seem to have, it's not working. And you give a lot of very compelling points about missing the greatest proportion of people who could benefit, and so on. I would also say I represent a division in a very affluent district, but my division has, according to the former Children's Centre, the greatest health inequalities in South Cambridgeshire. And I'm certainly aware through our primary school head teachers of the inequalities in amongst children in school. So I'm very interested in exploring what you've set out here, and I'm sure we're going to have a lot of discussion, not just today, but we have a lot of discussion to do with our health partners. This comes at a moment when the ICS has, is in its early stages, and prevention is sort of our call. And so it's incredibly appropriate. It also meets the health and all policies approach of this council. And one of the things that I find so compelling is it relates to all aspects, all levels of local government, because public services and access, I mean, you somewhere in there you mentioned transport, you talk about education, employment, family, community, and we can put money into skills, but if you can't get to your skills training, what's the point? So I think it comes at an incredibly important moment of transition in very many ways, and I'm really, I don't often jump up and down about a report like on a long agenda, but this one really made me feel very, very excited, to be honest. Thank you.
Thank you. Fenland as our geography area came up 2 or 3 times in your presentation, Jyoti, and I just want to make very clear that this report looks at the downside of the universal approach as well, and actually says this is about addressing where we haven't succeeded, where we should have done over the years, and will save lives in Fenland. So I just want to make that clear before Councillor Bowden possibly puts a different view.
Thank you very much indeed, Chair, for putting my comments into your context. Would you please correct me if I say something wrong at the very beginning of my speech, because I don't want to misquote you. But I think you just said at the end of the last item that it's not a controversial statement that you are making, that the spend on our services should be proportional to the need that we've got, but that everyone should have access to our services. And I think that's what you said. And if I got that wrong, correct me now. Roughly right, that's good. Unfortunately, whilst that may be fine in theory, in practice, we have a problem because we are limited in the amount of resource that we've got available. That resource very often is money. Sometimes it's to do with labour availability, and there are other constraints, including geographical constraints as well. But I'm afraid that that is a controversial statement that you made, because it works very well in theory. It doesn't work in practice, and we have to make choices, and hard choices. Now, I don't want to say anything which is in any way disrespectful to the Director of Public Health. I do want to say that at the very beginning, but I fundamentally disagree with some of the comments which have been made by the Director of Public Health in this report. Having said that, it's not a case of having a binary decision between universal or targeted services. You have to look at each individual intervention that we make in its own context. And the Director of Public Health gave a very good example of a very good universal, or almost universal intervention, which is fluoridation. And that has worked remarkably well. So it's not always the case that universal interventions don't reduce inequality. That's a great example of one which does. But Director of Public Health talks about the Marmot report. Well, the Marmot report, of course, was a politically motivated report from the Secretary of State at the time. It was a report which has never been accepted by central government. It's still unaccepted. And many people say it fundamentally fails to distinguish between correlation and determination. Now's not the time to talk in detail about the Marmot report, but it has to be said that the universal approach which there has been generally towards public health, and our Director of Public Health is not on an outlier here in terms of what she's saying. What she's saying is very much what many directors of public health say around the country. I fully accept that. But she also said it hasn't worked because we've seen, at least as far as health inequalities are concerned, that despite that approach on a national level over a long period of time, health inequalities have widened. So it doesn't look in empirical terms as though it's necessarily the case that a universal provision has reduced health inequalities. Now, I'm talking here specifically about geographical health inequalities and inequalities of health outcomes. And I believe personally that the more you concentrate resource on those areas with the poorest health outcomes, the more likely you are to reduce health inequality. And there are exceptions to that, I fully accept, but I would say that in general terms, that is an appropriate starting point to have, and it is not the one which the Director of Public Health is suggesting. And one of the problems that we've got with universal services is that it's easier for those from less deprived areas to access these services very often for a number of different reasons. Maybe they're better informed and therefore they're able to access more easily. Maybe they have sharper elbows and are able to access services more easily. But generally, universal services are accessed more easily by those who are in the less deprived areas than those who are in the more deprived areas, unless some degree of targeting takes place. And I think that it is very important that we recognise that that's the case. But here in Cambridgeshire, as I was just talking about with mental health, we don't start on a universal basis where everyone is even treated equally, let alone equitably. I gave examples in mental health where the area with the greatest mental health issues has the poorest service as far as we're concerned. Now, I know we're not deliberately targeting those areas which have the least need. I know that's not the intention that we've got, but that's what we're effectively doing in terms of many of the services that we've got. I gave 3 examples from mental health before. I could give a whole host of examples on health, where the same is the situation, where the areas which have got the greatest need have got the least access to services, and that cannot possibly be correct. If only everyone had exactly the same access to services, that would be a massive improvement on the situation that we've got at the moment. Now, if we look at health, just as one example, and I'm always told off from giving individual examples as they're being not representative, but we have 2 new hospitals appearing in our area, both of them in Cambridge. Now, I'm told, of course, they're available for everyone, but the access to those hospitals for people from, for example, Fenland, where both in terms of cancer and in terms of children's health, where I do accept determinants of health are important, the access to those 2 hospitals for people in the area which has the greatest need is going to be much more difficult than for those who are in areas which are less deprived. I'm sorry? Oh, I'm really sorry. I'd like to put a challenge to you, Chair, particularly, because this is a political challenge as much as it is a challenge to the Director of Public Health. And that is, if you continue to say, and I think you are continuing to say, Chair, that we wish to reduce geographical health inequalities within the county, if we are, then let us have a very clear measurement of those health inequalities and publish that. Let us have a target for how much we want to reduce that measure by, and let us show each time we have a new policy or a new procurement decision, let us show how the decisions we are making actually assist in reducing those health inequalities. So I'm setting a challenge to you, Chair, and to the Director of Public Health. If we believe what we're actually saying, that we want to reduce geographical health inequalities, let's actually work that into the system of decision-making that we've got so that we measure where we start from, say where we want to get to, and show how the decisions we're making help us to get from one place to the next. Thank you for your indulgence, Chair.
No, thank you. And I've made a note of that. I promise I will reply at the end of the debate. Councillor Slatter.
Thank you, Chair. Yes, I think both my political and nursing career spans all sorts of things, like avoiding stigmatisation in time of AIDS by putting your gloves on for everybody, even if there was only one child you had a suspicion of. Classic. Your recall of fluoridation misses out on the massive amount of controversy there was. And it was probably only the well-educated middle-class mother who dripped the fluoride into the mouth because it wasn't available until we'd allayed people's fears. So universal offers, vaccination is our more recent lesson to be learned. Insofar it was there, it was available, and there was still resistance. And I think that's because we must recognize times have changed. And this is one of the big changes, isn't it? Because people's access to information is much more universal than it used to be. The reliable information is possibly less accessible than the unreliable, but this is an absolutely key part of our weaponry, I think, is to use social media and the massive opportunities that go with that. And that must balance where we have in the health service, this battle between universal offer and specialisation. Now, you draw attention to hospitals, I think possibly a little unjustly, because in the days when you would have a cottage hospital not too far away and a bus to get to it, then you recognise that maybe one hospital had a bit more to offer than the other. But more and more people are not prepared to accept the things on offer on a universal way. They want the specialists because they read about them. And so we have to balance that. And so having an Eastern area children's hospital, and remember it's a regional resource, rather like Royal Papworth, it's a regional resource. You want to be able to get people there, of course. And that's why I'm so glad we've mentioned transport, because that is key. Because although this may have revolutionized what people know, the lack of public transport makes it almost irrelevant for some people. And we really must get at that. For young people's mental health, to be able to get together with other people and to have things that are universally on offer. And although the drama club might be a place that's run by somebody who knows about mental health, it's not a club for people who are depressed or, not got good mental health. It's universal offer, but the benefits are there as well. So yeah, I mean, this is very familiar territory for me, as you can imagine. And I do welcome as a politician this report, because I battled in Cambridge City as a city councillor against the assumptions people had about Trumpington. People thought we all lived in big houses, and it was very difficult to get the community development officers down there and so on and so forth. And yet in Cambridge, we have a relatively mixed, a heterogeneous society. We don't have big ghettos. We have streets that have got a tremendous range. And being aware of that range is something that we as local councillors can do. We know that there are lonely old people in big houses, and to make something available to them, however it can be done, is really important. We know that, so we need to share good practice. So even if we find that there's things are better in somebody else's division, we want to get that for us as well. And so the people who set up successful repair cafes or men's sheds or whatever else on the mental health line, this is something we can share. And I think that's one of our big jobs as the county council, is to share good practice amongst the councillors, as I'm sure the officers do already. Thank you.
Thank you.
It's not a question, is it? Sorry, but I really wanted to welcome this report. Thank you.
Yeah, you don't have to ask questions. No, contributions is fine. It's a really good debate, but can I ask people to be concise so we don't fall too far behind? Councillor Howell, please.
Thank you very much indeed, Chairman. I think that the Director of Public Health is in a very invidious position, because if they go for universal, people want it targeted, and if they go for targeted, people want it universal. So I accept the report and what you're saying there. It's very difficult, as I say, and I look upon it, and I read it, and I was very interested on the universal approach. And to be honest with you, I have no great means of that. What I'm going to ask for is, within that universal approach, when you look at different areas, and sometimes we don't know the results of 10, 20 years and how we're doing things, it's very difficult to measure it in the short time period, which we sometimes think of, which is an election cycle. So it's very difficult to, and I understand that. Within that particular universal approach, will you be looking at any particular groups that have a particular emphasis? And I'm just going to pick one, for example, of alcoholism within there, and then start to target within that universal approach, those what could be a very subset, very minority approach, and how you look at that. And Councillor Slatt has already said about it on the beginning of her statement, as opposed to question, with regards to the information and today's ability to have information where before we just didn't have that ability to be able to get information where we do now. So, and I'm just going to use social media, and I'll say one in particular, which is Facebook, but also you've got the Snapchat, Instagram, very targeted for within that. So universal approach I have no problems with, but are you going to look then at groups within that particular area? Thank you very much. Thank you, Chairman.
Thanks to you. Councillor Daunton, please.
Thank you. I had 3 points, but Councillor Howell has made one of my 3, so I now have 2. One is very, very general. I understand universal to mean for all, so it's not depriving anyone, it's including everyone. My very specific point is about uptake, and the report, I think it's an excellent report, challenging and thoughtful. You mentioned in your presentation, Jyoti, the issue of uptake, and I would like to give you the opportunity to say something more about that and the challenges of uptake.
Thank you. Councillor Wilson, please.
Thank you, Chair. I agree with all of Jyoti's conclusions, recommendations. I'm very happy that we should start with an universal intervention, particularly with the young people and in pregnancy and childhood. We did some years ago have quite a universal health visitor system and school nursing system, which my wife was part of, and that has been dramatically cut. And I think if we were to reinvest, not necessarily us, but our partners in some of that to get to early childhood, that would be really good. And then some form of targeted approach is clearly the way to go when you've identified the need. And this is where I would definitely agree with Chris and Mark. We do need to be able to monitor the impacts of our actions, not just our actions, but those of our partners as well, and try and ensure that you can say, well, we did this and the result was that. And that's the only thing which I would add to we need to your list of activities. Thank you.
Thank you. Councillor Gay, please.
Yes, a point of information for Councillor Bowden. The 2 new hospitals in Cambridge are largely funded by huge benefactions and grants from research charities. As well as providing patient care, they're also aimed at leading edge world-class research. And therefore, unfortunately, the benefactors and charities would not see it as an advantage to be located in Wisbech. If Councillor Bowden wants to blame anybody for the inequalities that we see, he should look to his government, which has systematically underfunded the National Health Service since 2010. They were told at that time that they had to increase the budget of the National Health Service by 3% per annum in order to cover the demographic changes that were going to occur. They insisted on this austerity and 1% above inflation. And of course, in 2019, the current government made the notorious pledge to build 40 new hospitals. And so far, as I understand it, none have been built.
Thank you. And Councillor Murphy, please.
Yes, you'll be pleased. It's very brief. It's a comment really that I very much welcome this report. I think it's one of the best reports I've read since I've been a councillor. I really support the idea that we're dealing with people, you're not just badged with the geographic area you happen to be living in. And I appreciate there are challenges with universality versus targeting, etc. And yes, we do have to monitor the impact, but I think conceptually, this is such a strong way forward, and that sort of a holistic approach I thought was really excellent. So really just thank you.
And my own contribution. I accept the argument that hard choices have to be made. And I think what this report tells us is that some wrong choices have been made in the past for very good reasons and for very good objectives, but they haven't worked. So in that lowest quintile that was referred to in the presentation, the targeting at 30% of the people hasn't particularly worked. But it's also failed the 70% of the people who suffer health inequality who it hasn't reached. And this is a really honest attempt to say that we did make, or this council made, some bad choices, and we're going to try and make some better choices in the future. On this question that was put to me about geography, well, we've got our KPIs already, and we'll have the report later. We can always review which KPIs we use. I'm completely open on that. But as already been said in the presentation, regularly geography is considered when health inequalities are measured. That's part of what happens anyway. So and it's definitely not my view that the aim is lowering geographical health inequalities. It's my aim that we lower health inequalities wherever they are. And so I think that should be the driving KPI. And I think that's what the direction in which this report is taking us. And my final point is this: if this administration is trying to do something different and better on public health programs, it's trying to say that we're going to, that we accept that good programs for good reasons were run in the past, but to some extent haven't succeeded. And instead of just doing more of the same, we're going to place extra scrutiny on what will really make a difference. And I see this report in that context. And I thank our Director of Public Health for having the courage and the honesty to ask some very challenging questions. I think it's provoked a really good debate this morning with different points of view. I'd be the first to accept, and I think it will with our health partners, but I think it's been an excellent use of the annual report this year. Jyoti, to reply to the debate, please.
Thank you. So I don't know where to start with all of that. I think the first point I would make is that we present things by geography because that's how we have the data available to us. It's very difficult. We don't have a strong measure of individual deprivation, health outcomes by individual. And so we use geography as a kind of a proxy for those inequalities. And I would agree with Councillor Howard that I'm interested in reducing health inequalities. We just happen to present them by geography. There are many, many others: gender, ethnicity, etc., etc. And if we just focus on geography, we miss all of those other aspects of inequalities. I think the question about resources, I think it's not a binary decision or a choice. You know, I'm saying universal first by default, supplemented by targeted interventions as appropriate and based on evidence through the systematic identification of individuals rather than geographical targeting. And if we do that, and if more individuals are in need are in Finland, which, you know, there will be a higher concentration of individuals in need in Finland, the resources will by default end up in the geography where they're needed most, because we're systematically identifying individuals who are in need. You look perplexed. Okay, I'll keep going. The point about social media, absolutely pertinent. You know, our competitors are using social media. You know, they're peddling alcohol, they're peddling cigarettes, they're peddling all sorts of unharmful products incredibly effectively. And we've allocated some money to behavioural insights through our budgets, and we will use that to inform targeted social marketing campaigns to promote access, for example, where there's inequalities in access, but it will be based on insight and understanding of why people don't access or what the motivators would be. So there's some of the things that we're going to do. Your point about alcoholism, almost proves the point that I'm trying to make in the report. So actually, all of the public health funding for alcohol is going into treating alcoholics. And we're missing the population harm that alcohol is doing in the majority of our population who are quietly drinking harmful amounts of alcohol at home and not reaching any services. And it kind of proves the point that I'm trying to make here. We need to go for universal services as well. And actually all we're doing is targeting in terms of alcohol. I think I've covered my, actually health visiting and school nursing are ours. They're our services. I think the provision in school nursing is inadequate. The investment we're making in our adolescent population is not as much as I would like it to be. There's a lot more going into health visiting. I don't think we've cut, certainly as far as I'm aware, we've not cut the health visiting budget since it's been in the council. There are issues in terms of recruitment. So they're under, their workforce is not at full complement because they're struggling to recruit, and that is coupled with the COVID impact is having an impact on our ability to reach to deliver our mandatory universal checks, which is something that is of great concern to me in the context of the report that I've presented. I think I've addressed most of the points that were, or questions that were raised. Thank you.
Thank you. I'm going to move this on there, but I think it's been an excellent debate. I'm sure it'll be well noted and the different views around the table will be well noted. 30 seconds, Councillor Daunton. With your microphone, please.
Just to ask Jyoti if she could address my point on uptake.
Yeah.
Sorry, I thought I did. So I think what we need to do to address uptake is understand why people aren't up. So behavioural insights, and then social marketing, or changing our interventions to address that. An example of that is uptake of vaccination. Our kind of door knocking attempts really didn't make much of a difference, but we did do some insight gathering, and in one case we identified that older people weren't attending a site for vaccination because they were concerned about parking. Would there be parking available, and would there be toilets? And so then the letters then included, there will be car parking and there are toilets. So that's how we would use it.
That's a brilliant example. This will be also going to a development session of the Health and Wellbeing Board in January, and so there'll be or soon anyway. Am I wrong? Sorry.
Not board. The health. Yeah.
Sorry, the Health and Wellbeing.
It's called.
Yeah. So that it'll provoke a similar discussion, I'm sure, with our health partners. Thank you again to the Director of Public Health, but also everyone for contributing to that debate. Can I ask people to just be self-disciplined in contributions? I think we can speed up a bit on the next items without prejudice to dealing with them properly, of course. The report is noted, so we don't need to vote on it. Item 6 is the cardiovascular disease prevention strategy, and Val Thomas is here to present it.
Thank you. This strategy has been produced by working in partnership. I've worked with the lead GP from the ICS for cardiovascular disease prevention, and we've been developing it over the past year. The importance of bringing it here is that 25% of deaths nationally and locally are attributed to cardiovascular disease. And the other big significant factor is that it's a highly preventable condition. And I think that probably, I think I should just say those two things and then go away almost, because I think those are the really critical things. I think that it strategically, nationally, for the health system, it's in the 5-year plan. It's in our local. It relates very well to some of the priorities in the Joint Health and Wellbeing ICS strategy, and also the prevention side of it, and I'll just describe a bit more in a moment. It very much fits with the public health prevention agenda. Like, prevention is sort of almost like the substance of public health, and this really does give it calls for the public health interventions, both I think those early determinants, but also what we do in our services as well. And of course, we have allocated some public health investment, reserve investment to promote and develop prevention in primary care, but also to strengthen some of our services, most notably that I think Jyoti said earlier about the smoking and pregnancy interventions, but also strengthening the NHS health checks as well, and others. The strategy itself focuses on behavioural risks, so that's smoking, diet and so forth, but also then more secondary prevention, and that's to do with the identification early of people so that we can make those interventions, whether it be better clinical management, but clinical management is very much enhanced by that behavioural support as well. And that very much is the focus of the strategy, and how we can build on what we do already, and also strengthen those clinical pathways. Where we are at the moment, I think at the end of the paper, I list a number of interventions which are currently being taken forward and strengthened. Our services, I think we've been quite challenged by COVID. I think we are recovering, but there's also some way to go. I think we always come back to alcohol, we come back to smoking, and I think those are two that were hit quite, and it's emerging more clearly now, being hit by COVID. There's a lot of work to be done there. And of course, obesity is there, 70% of our population. The work we're doing with the ICS partners is strengthening the identification in primary care, but also it's how we use our resources. For example, we commission health trainers. In the health system, we have health coaches, we have social prescribers, and these sit both in primary care and in secondary care. And really, we don't really use them efficiently in the system and as most cost effectively as well, to use that terminology as well. So there's a lot of work in terms of how we work as a system to pull these resources together. We are working again with various partners, the East of England Academic Health Science Network, in terms of working at bids that will again help support this, but it is very much about changing that system and making that shift back to prevention. And I think that's the focus, that CBD, it really is having a huge impact on the health of the population, but it is largely preventable.
Thank you very much. Councillor Wilson, please.
Thank you, Chair. My one question, Val, is at the top of page 109 about the ambitions for reducing adult overweight obesity levels to pre-COVID times by 2030. That doesn't seem a particularly ambitious target to me, and I just wonder why that's in. And then secondly, it talked on the next bullet, it refers to reduce inequalities in overweight stroke obesity, but with no numbers or dates around it. Thank you.
Thank you. Councillor Daunton.
Yes, also on page 109, the achieve a 10% increase in the number of adults who undertake 150 minutes of physical activity. I hope that the two parts of the county are talking to each other, and that you're working with the Active Travel Strategy Group that's looking at increasing the opportunities for walking and cycling.
Thank you. And Councillor Bowden, please.
Thank you very much indeed, Chair. I was particularly struck by figure 1, the schedule of CVD in primary care networks, which is after paragraph 2.1. And I'm perfectly willing to accept that if we wish within our overall ICS area to have the greatest overall effect in reducing CVD, then the universal approach, which is fundamental to this, is the best way of doing that. I'm quite willing to accept that. But the price you pay for doing that is increasing the inequality between the different areas, because you will get better results out of some of those areas which currently have some of the lower levels of CVD. And what's so shocking about the figures that we have in front of us in figure 1 is that going by the different PCN areas, The worst PCN areas have CVD mortalities, both for all ages and for the under 75s. They have mortality rates almost 3 times as great as the mortality rates in those areas which have the best results. And that's a shocking level of geographical inequality. And I was disappointed to hear you say that you didn't aim to reduce geographical health inequalities, Chair. And I know what you qualified that by saying, but these geographical health inequalities will increase if we continue to have a universal approach. Now, having said that, I accept a universal approach will have the best overall effect for the area as a whole. And it's a matter of, are we willing to accept having increasing geographical variance in terms of health inequalities for the sake of having the best overall health outcomes for the population? And I think that's a really important question, which does deserve a lot of thought over a long period of time. I'm not expecting an immediate answer to that. Thank you, Chair.
Thank you, Councillor Van der Ven.
Thank you. I wondered if you could say something about the success or progress of NHS health checks and the increased rollout that we have got behind, and the state of affairs with primary care to follow up the outcomes of those health checks, whether, you know, appreciating that primary care has a huge load to catch up with and has to find its footing. And I just wonder how you feel that's going. And then just, we have got a really fascinating thread now on geography, but I'm mindful of what Jyoti said about different ways of looking at our society, not just by geography. And what was interesting during COVID and the management of outbreaks is how often we were looking at workplaces, as opposed to, we didn't even know where those workplaces were, but we knew it was a certain industry that was going to be more prone to a COVID outbreak. And I wonder if we can start to think in broader, well, different terms as part of this discussion. If we can move away from geography and understand demography better, because demography is changing. We are in such a point of transition. That's probably not my place to say, but I think you've put the challenge to us, Jyoti, in terms of how we look at our population and how it is delineated in understanding these things. Thanks.
Thank you, Councillor Slatter.
It's a question this time. What Councillor Van der Ven prompts me to say, occupational health is really important, because I think occupational health professionals are well versed in the dangers or the hazards of their own particular workforce. And we know that some jobs are unhealthy, and they make it very difficult for people to lose weight for all sorts of reasons, various sorts of drivers. It's really difficult to be a healthy driver. So I'm just wanting to ask what sort of links we have, and certainly if there is public health funding where we can be in cooperation with employers through their occupational health professionals, if they have them, or even just publicity and well-being networks, that sort of stuff. That'd be good to know. Thank you. And also, if we know how we're doing it, we can then prompt our local employers to make the most of it.
Thank you. And just from me, I think we've had the universal debate, to be honest, but I won't stop anyone saying anything they wish to. But, my simple point, so that it's heard, is the previous approach, driven by geographical issues, might have made previous generations of politicians sitting around tables like this in Old Shire Hall feel better because they were targeting greatest need, but didn't work. And this new approach is one that may work better, and we hope to work better, including for the people in the most geographically deprived areas. I won't say more than that, but if this is an example of what we're talking about, that would be my response. My only additional point, and Val's heard this before, but I think it's really important. We're having a series of really important health strategies coming before this committee, and updating our strategies in those areas. And this is brilliantly written and evidenced, by the way, thank you. But I do think in bringing forward these strategies, we need to have more cognizance to what hasn't worked. And I think that past debate is an example of us trying to do that. And I appeal for that to be part of future health strategies. But secondly, also to explicitly evaluate different approaches in other geographical areas, not within Cambridgeshire, but around the country, so that we're showing our public that we are learning from best practice from elsewhere, because it's a brilliant report, but I would have liked to see that higher outward looking focus. And I hope that can be very much built in as further health strategies down the line come forward. Val.
Sorry, thank you. I think the first question was about targets, and they should be perhaps a bit more stretching. Some of them were national. They are set by the NHS 5-year plan, and then there's a national target around physical activity as well, 150 minutes. There are very few of them that are actually local. Where they are being worked through now through the particularly around obesity, are being worked through it's one of the priorities of the joint health and wellbeing integrated care strategy. And although we put some initial targets in there, we are refining them at the moment. So the local targets, as we are digging down more into information, also it's the impact of COVID has skewed everything. So we are looking more closely at that. So I think the national ones we are kind of stuck with, but I think the local ones around obesity are movable, and I think stretching targets are important. But I do think obesity is a very, very difficult area to shift, and it's not something that happens overnight, and it's so multifaceted. But we will sort of review them. The next one was again, we've had the discussion around the issues raised by Jyoti's report, but I suppose my comment only be on it. It's very much about the how when you target, which comes back to the behavioural insights. And I think a lot of our interventions perhaps haven't had as much traction as they could have had if we understand more how people interpret those interventions, and therefore that governs their responses. And I think that's a really important bit of intelligence, which I hope our commissioned behavioural insights will help to improve. NHS health checks, we've finally got going on that. It's contractually anything that with another organisation does take a lot of time. But we are starting to see some improvement, and numbers are picking up. We've also commissioned more again from our lifestyle service, which has the adaptability and flexibility to go to different places, and again use their understanding of the barriers to NHS health checks. And there's still a lot of misunderstanding about what NHS health checks are all about. In terms of that following up afterwards, in a sense, I think that the beauty of NHS health checks is that they do identify a clinical problem. So there is a sort of ethical dimension to it, in that, you know, we have identified a person who has pre-diabetes or even diabetes, and then referred. So I think in a sense, in terms of the primary care response to health checks and their follow-up, I think we get quite good feedback on that. So I think that's all I can say about that. I think workplaces, I can probably talk for months and months about workplaces, but it's one of my areas that I'm particularly interested in, and learned a lot during COVID, in fact, about how it's the workforce and the way the workplace is constituted, and very important in that, and they're wide-ranging drivers. I think in terms of occupational health, I think probably the biggest concern is for small and medium-sized employers who don't have access to those resources. We work very closely with a lot of employers. We work closely with the combined authority. We work closely with the districts, with their economic development officers, and benefit from that in terms of the links that they have into businesses. and support them in terms of information. We work closely with the Department of Work and Pensions as well, and train their staff around what's available in terms of support. But I think it's recognised nationally that occupational health is a very unequal resource for a lot of people in work. And I think you're looking at me, Councillor Slatter.
Okay, we just can't extend the debate through because we've run so far behind.
Sorry.
But please, in the break, again, I'll give you 30 seconds because I'm trying to be on best behaviour.
Could I have an answer to my active travel?
Sorry. Oh, your question was around.
I wanted reassurance that you're talking to the active travel.
Oh, absolutely.
Group, yeah.
Yeah. That was. Apologies. Yes, we do talk a lot to active travel, but I think one of the things about active travel is you can put active travel opportunities there, but getting people to use those active travel, and that's our challenge, I think.
Vote for the sustainable travel zone. So thank you very much to, I don't know why I said that. Thank you very much to Val Thomas. The recommendations are to support A, the high level outcome ambitions, B, the focus upon behavioural and clinical risk factors identified in the strategy, and C, the planned interventions to mitigate the behavioural and clinical risks. Anyone want to vote on this? Just nod at me if you agree that, please. I'm looking on both sides of the table, and from all the groups I see assent, so that is agreed by consensus. We now go back to our favourite subject of block contracts, whether they involve cars or not. Item 7, rapid discharge and transition block home care provision. And Ruth Miller is very welcome at the committee. Thank you for coming, Ruth. Microphone needs to go on.
Okay.
That's right.
Sorry, can you hear me? Yeah.
We can now. Thank you.
Thank you very much. So approval is sought to recommission a reduced level of block home care provision on flexible contract terms to ensure the council can meet demand for care whilst a new place-based model is implemented. This is part of the home care transformation work under Care Together, aiming to make it easier for people to deliver care in their local community. We will still require a reduced level of block provision whilst implementing the place-based home care model to ensure continuity of care. The existing block provision has been analysed and feedback has been gathered to better understand demand and areas for development. With this information, we have been able to tailor the new specification to improve how the service is delivered, including more capacity within the morning calls to provide better choice for local people, as well as more zones in which the cars operate to ensure better rationalisation of care calls, resulting in less travel time for care workers, better quality of service for people, and lower carbon emissions, which is also benefited by the requirement of electric cars being used by the service provider. And that's it.
Very concise, but also very well argued. This really comes back to the question Councillor Costello put to Will Patton earlier, and this is evidence of actually it being implemented. Anybody want to comment? Councillor Wilson.
Thank you, Chair. On page 136 in 2.8, it says, for this reason, we propose an ultra flexible contract period, a contract term of 1 year, with the option to extend for a further 4 years in 6-month increments. If I were somebody interested in one of these and was thinking, I'm going to have to buy a car to deliver the service, I wouldn't be interested in only having a commitment for 1 year. Why have we chosen 1 year in this instance when other contracts have a much longer period?
Anybody else? Just my own steer on this. I want us to move further and faster towards locally place-based care. And I think the Vice Chair as well. And I think the officers are steaming ahead as far as they can, but they have to put in a safety net to make sure that care is there for people who need it, and that how far we can drive down centralised block care to be replaced by localised, personalised, more personalised care
who knows? But we need to go at the speed we can, which is why I think the 1 year in this instance is justified, because maybe we can go further and faster in doing it. It's a fair question though, and we'll hear the answer. But certainly in terms of the steer, I think that Councillor Van der Ven and I are discussing with our senior officers. We want to, in practice, we'd like to go faster than this, but we recognise that in the end, we've got to make sure the care is there for people who need it. Yes, Councillor Van der Ven.
Thanks. If anybody by chance is following this meeting, just so you know, the term block cars and block care and block cars is something we're always well asking about. It seems to be a traditional old denominator, but drive, speed, further, faster, and steer are words that you just used just now. I'd like to ask if you could speak a little bit to Care Together and the footings that you see taking shape, because this depends on Care Together evolving well. Thanks.
And just for any members of the public watching this, it's all jargon. We're sorry, we don't like it any more than you do. But block means doing a contract in advance for a number of places. And the alternative is spot, which is as the demand comes up, we buy it one by one. And we obviously get a better deal financially in terms of block, and the providers get more certainty in terms of block, but then we're stuck with it. Whereas spot, they get their certainty and we end up paying more money, and getting the right balance between those two is what we're talking about here. So if there are members of the public watching, that's what we're talking about. Ruth.
Thank you. So in terms of the 1 year contract with the 6-month extensions up to an extra 4 years, we did do extensive soft market testing. So we have spoken to the market and found out if providers are willing to do this. The main reason behind it is because, as has previously been said, we really do need to look at our block provision, because it's not necessarily the most efficient use of money, and it's also doesn't provide the best choice for people, and that's kind of what we're looking for. So we are moving towards a place-based commissioned model, and that is intended to fulfill the demand that the CARs are currently fulfilling. So the CARs are currently providing care in rural areas, hard to place areas, county borders, that kind of stuff. It's very short term, it's very quick to be placed. So we are hoping to create a model where that's not needed in terms of block buying. It's where we can place people when they come out of hospital in their local area, cared for by local people in the way that they want to be cared for. So that's the first point. And in terms of Care Together, so Care Together is a place-based approach in terms of home care, which I'll talk about, and maybe we'll want to talk more about Care Together as a programme. But in terms of home care, the home care model has got a place-based zones. So the county is going to be split into areas. Those areas are going to be analysed for demand. So we're going to look at what people's care needs are specifically in those areas. We're going to look at how we can tailor services to meet demand in those specific areas. We're also going to have an introduction of rates, sliding scale of rates. So we're going to have urban rates, semi-urban rates, and rural rates. And that's being that data is being used through the ONS, LSOAs, all of that information about that providers give us, that we have ourselves on demand that we already provide. And we're going to look at having spot purchase or block purchase of those kind of rural hotspots. So the very hard to place areas might have like mini block contracts. And we're also having specialist rates for learning disabilities and mental health and complex care. And we've done a lot of engagement with the market on this, as well as service users. And in terms of sort of rattling on, but in terms of Care Together, there are place-based commissioners that are working specifically on this in the specific areas. So they're going out, speaking to the community, what is it that you need? What's already been provided? How good is it? What can we change? All of that stuff. And then that's being built into this model. And we're also doing a lot of work on workforce development as well. So marketing, trying to improve the image of care workers, having like a career ladder and pathway. And we're working with colleges and things like that to have free additional care. Oh, that's it. Yeah, okay, that's it.
That was a very, very brilliant and concise explanation of the whole Care Together programme. Will did talk about this earlier, so and I think this committee is reasonably well informed on our direction of travel on that. Thank you very much. The recommendations are to approve the recommissioning of the rapid discharge and transition block home care provision on a 12-month basis, extendable up to a further 4 years, 6 months at a time, with a total contract value of £2.9 million over 5 years from June 23 to June 28. Terms and conditions are applicable. And B, delegate approval of awarded extension periods. Thank you for one laugh there, to the Executive Director of People and Communities. Does anyone want to vote on this? Nod at me if you agree. Yes, nods all around the room, agreed by consensus. Thank you very much to Ruth. We move straight to item 8, insourcing of a supported living service, page 141 to 148 of the agenda pack. And Tony Borden, Commissioner for Learning Disabilities and Autism, is here to present this report.
Hello, everyone. Oh, you can hear me. So committee's been asked to agree the insourcing of a supported living service in Whitton near Huntingdon. This forms part of the Learning Disability Partnership Section 75 agreement. And insourcing will be at an annual value of around £633,214 per annum. This will incorporate the harmonisation of terms and conditions of staff who are transferring under their present terms of employment. The supported living service is currently commissioned from an independent sector provider, which acts as both landlord and care provider at the service. However, they've taken the decision to sell the property to a new registered social landlord and therefore have given notice on the care and support in the scheme. Under this proposal, the Learning Disability Partnership in-house services would undertake the management of staffing at the scheme, which is a 6-bedded unit, which comprises of 5 bungalows with 4 current service users. I can assure people that tenants will remain at the scheme. They will have new tenancies put in place. And we also envision that the 2 vacancies at the scheme will be also recruited to and filled as the service passes across. There are quite a lot of benefits of insourcing. The reason why we've gone down this route is that it fits with the administration's vision and policy around insourcing and considering it. The current provider has had significant difficulties in recruiting, which is part of one of the reasons why it's actually made the decision to sell the site. We've done some soft market tests and call outs to our local care providers in the vicinity. We didn't yield a response, which was successful. So we know that we have really strong in-house services locally. They have good levels of staffing, a good pool of staff, and we have other local services. They have high levels of staff training and supervision. And I think we're considered to be a recruiter and an employer of preference. So we would also basically be 2Ping the staff across as part of this service and insourcing. And the costings of this will be in the region of, as I've said, £633,000, which is an increase of £106,000 in terms of the service. But this will allow for the harmonisation of the terms.
Thank you very much, Councillor Van der Ven.
I'm so sorry, Chairman. May I just interrupt? I may, because I don't know all the details, have a pecuniary interest in this, so I'm not going to take part in any part of the debate.
Yeah, the current provider wasn't named, so that it was perfectly possible that you wouldn't have spotted that in advance. And thank you very much for drawing that to our attention, which will be noted in the minutes. Councillor Van der Ven.
Thank you. Just a small question really on the workforce situation in this particular area. It's nice to hear something positive about a workforce being ready and well suited. And I just wondered, what are the reasons for that? Is this something you'd expect to see elsewhere? Just curious about the local conditions.
Councillor Bowden.
Thank you very much indeed, Chair. I have no problems whatsoever with the proposal that we have in front of us. It is a cost-effective proposal and it will result in, I believe, more and better care being given for specific individuals, which is really important. I do have an issue, and in fact, the comment which has just been made about a potential interest just highlights this. I read through this report, and nowhere within the report did it say, or was it available to the public, about where we were talking about. Not necessarily which particular property, but even what the geographical location of it was. Now, it wasn't a secret, and it's been mentioned that it's in Whitton, which is fine, it's not a problem, but it just wasn't mentioned at all in the report. And may I just ask that in future, when we have reports, unless there's a good reason to do so, if it's about a particular location, that we state in the report what it is, if only because, as we've just seen, members may have an interest to declare and they don't know whether they've got an interest or not. Thank you.
Thank you. Councillor Wilson.
Thank you, Chair. When I read this first, I was very surprised that it's being held in public session, because it refers specifically to allocating a contract to, in this case, us. Rather than being a general procurement exercise, it's bringing a service in-house with two options considered, and therefore I would have expected it to be confidential. But my other questions are, does this set a dangerous or otherwise precedent that other providers will think, oh, well, we can give up our services because we can rely on the county council to take them on? Now, I know it is our preference to start to bring things in-house, but we do need to be aware, and this case is a clear example of what the increasing cost that might be if we do it. And then the final question is, what do the staff and the families and the individuals who currently live there know about this proposal? Because once they read this, everything is in the public domain, and therefore they will become aware if they're not already. Thank you.
Can I just take that point first about whether this is appropriate to be an open session or confidential session in relation to the provider, the staff, the provider and the users there, and we'll just deal with that separately and then we'll come back to the other points in the debate. I'm looking partly at Tamar and partly at Tony. Tamar.
The implications and the legal team will have looked at the report, and if they'd had any concern, then they would have advised.
It's definitely gone through the interim monitoring officer. So that, and it's, of course, it's a big public policy decision like the other decisions we take. So the balance of the argument is that it should take place in public. It's my understanding, and what Tamar has just said, as I also understand, and Tony can corroborate that in her summing up, this isn't going to be new news in the facility. I think there have been preparatory talks and consultations there, but I'll let her sum up. Do I have any other councillors who've not spoken? Now, my own contribution on this. So I think this is a really interesting and important development. It does indeed reflect this administration's priority to look at a mixed economy between direct service and contracted service outside. It's actually only a very small example of that, but it sends a signal. You know, I would compliment what Councillor Wilson said by saying it sends a positive signal that we are interested in direct provision. And as far as I know, and Tony can comment, but as far as I know, this was a provider doing a good job to high standards, but it wasn't right for them to continue. And that by stepping in and offering a direct provision as an authority, we are guaranteeing continuity of service to the users involved, which is really important. And we are showing that we are open-minded. So if other providers come along, that could be a good thing as well as a bad thing. And as Councillor Bowden has said, there's value for money in this. So I think this is an area where we are sending a different signal as a joint administration. And the other real difference that this administration is making in this example is that we are talking about immediately harmonising the wages of the staff involved. And when these things have happened in the past between different providers as well as with the authority itself, that hasn't always happened. And I think that's a very important point of principle. I'm proud that that is the recommendation. Tony.
Thank you. Yes, in terms of the continuity of the care for the people, that's really important. The provider who is currently the landlord and the care provider has been there for many years. They're very established, but they have had significant difficulties now during COVID and pre-COVID in recruiting and retaining the staff to their area for whatever reasons. But also it's a 6-bedded unit and there's 4 people currently in place. So with our insourcing, we will intend, and we have referrals coming through, so we will actually, by insourcing it, bring better value because we'll be able to fill those places as well. If I can just comment on the sort of the confidentiality of this report, it hasn't been named. It's been managed around communications with families and service users until we've got the sort of go ahead to insource it, which will also ensure that the sale goes through. And in the new year, so early January, the current provider will be able to communicate with the families and the individuals who are living there, and also the staff members, and be able to do a very proper managed communication to explain what the sale is, what's going through, and the impact on all those individuals there. The concern was raising it initially, and we did some preemptive comms around this in case word should get out and people would be concerned, is that if staff thought there was going to be significant change in the service, sometimes they up and leave. And obviously we didn't want that impact, and we didn't want to be able to concern residents and families before we were able to give them the full story and to do the support. And actually what happens in January when we come back, when this has all been agreed, is that we can do the mental capacity assessments and the best interest assessments with the residents there. We can work with the new provider on the tenancies, go through the court of protection and all those processes that we need to put in place. And we will also have the statutory consultation with the staffing of that time as well. So it's very managed. By letting the name out in advance would cause a lot of consternation and concern, and particularly with a group of individuals for whom change can be a significant challenge as well. So that's kind of why we've kept it quieter around that. In terms of, I think Councillor van der Ven, you mentioned about the workforce. There are definitely pockets, and I think there's been some care suite studies. There are pockets and elements in different locations where for whatever reason it's quite difficult to recruit staff, and I don't know if it's because it's out of the centre of a particular town and it's a bit further away. You know, I think there's lots of impact on it in terms of the local demography, the transport, which is actually quite strong around there. But so yeah, however those reasons have come about, the current provider has really tried over a significant period of time, and we have also gone out to the local market and we didn't yield any significant support from this. So rather than lose a really valid and valuable scheme, we wanted to kind of insource and then also use that to the full capacity. And what I would also say around that is that the current provider has been supported by our contracts team over a period of time. They've really worked to establish themselves there, but I think it was also part of a wider strategic decision in their company in terms of the sale from that. But we wouldn't expect providers to simply hand packages back and then the in-house to pick that up. This has been very much part of a strategic direction for this. Thank you.
Thank you. I do think some important questions have arisen from what Councillor Wilson and what Councillor Bowden says about how we deal with these reports in the future. And I will undertake with the Vice Chair just to further reflect on that with officers outside of the meeting, because I think you've made some very valid points there, and which have to be balanced against what our officers have just said. And it's not entirely obvious to me what the perfect answer to that is, to be honest. So let's have a chat privately, and I do undertake that we should do that. So we now move to the recommendation, which is to agree the insourcing of a supported living support service as part of the service delivered under the Learning Disability Partnership Section 75 agreement at an annual value in the region of £633,000, including terms and conditions of staff transferring under 2P. Does anyone want to vote on this? No? Can you nod at me if you agree? Yes, I'm seeing that from you.
Chairman, could you notice that I did not vote and took no part, and I didn't even vote?
Yes, that's also so that's agreed by consensus of the committee, but with the minute recording that Councillor Howell didn't.
Thank you, Chairman.
On the or take part in the debate on the item. We've hit the 2 hours because I want to still give us a decent lunch hour. I'm going to just give a 5-minute break at this point. We will resume on the dot at 12:10.
So I'm now calling us back to order. Never in line. It is cold. It said -10 on my car. Temperature gauges. Okay.
Really?
-10. Might have been an exaggeration, but so item 9 on the agenda is mental health supported accommodation service re-procurement. It's on pages 149 to 158 of the agenda pack. And Guy Fairbairn, Commissioning Manager, Mental Health, joins us to present the report. Guy.
Hello, right, that works. So I'll be as brief as I can. This agenda item is for the re-procurement of a service to replace the current accommodation-based supported living service for people with moderate to severe mental health needs in Cambridgeshire. It's recommended to approve a new service to start from the 1st of July on a block contract, which will give guaranteed capacity and allow for a proactive and flexible approach to support with a strong emphasis on outcomes and for the individuals and monitoring of the key performance indicators within the contract. This will be for an initial 3 years with an option for two-year extension periods. Annual cost of this will set at a maximum of 1.210 million, which equates to 8.470 million over the total contract term if all the extension periods are exercised. An inflationary uplift will be added to this figure based on the agreed uplift strategy of the council before the contract starts. You've had the paper which has outlined the current service and gives greater detail for the proposed new service. So I won't go into any of that detail because I'm conscious of time. Just as a footnote, we have engaged within co-production with this during the summer of 2022, engaging with service users, provider, carers, mental health social workers, wider health teams and landlords to a really comprehensive report which has fed into this, which has proved really positive. It's the first piece of that I've been involved with co-production. It's really helped with 4 areas of this contract. So the procurement timetable is detailed in the paper and the process will be an open and fair and fully compliant with the council's contract procedure rules. So that's my very abbreviated version for you.
A perfect introduction, but also very good news for what you say about our consulting and involving service users in the decision making. Really good to hear that, as in all of our other cases. Councillor Bowden, please.
Thank you very much indeed, Chair. I beg your pardon. Thank you very much indeed, Chair. I mentioned agenda item 9 at an earlier stage in the meeting, and I'll just expand on that slightly if I may. I don't know, Chair, if I should be outraged or grateful for the content of this report. Outraged because of the 117 places available, only 3 or 4 would be in Cambridgeshire or Fenland, East Cambridgeshire or Fenland, and they would be at the lower level service rather than intensive level or medium level service. So you have a real inequality of provision being made geographically across the area. Or should I be grateful because that's better than what we had before? Now, this is a good example of how historically we have not been properly targeting the services that we provide and that we pay for to those areas which do have the greatest need. And as I say, I'm grateful for the steps which have been made here to try to begin to redress that balance. But the idea that health inequalities exist despite there having been targeted operations in the past are disproved by items such as this, where clearly the targeting hasn't taken place at all. Thank you, Chair.
Just for Guy's benefit, we've had a very long debate this morning about the virtues of geographical targeting, or otherwise don't obviously answer the point, but don't feel the need to go from first principles on that, because we've aired that extensively this morning. Councillor van der Ven.
Thank you. Thank you. Yeah, like Councillor Bowden, I really welcome the aspiration to make a much broader provision around the county where people live. And I have a few questions. My first is about property and workforce prospects in East Cambridgeshire and Fenland. And I also wanted to ask about what the provider market is looking like and what can be done to improve it? I know that's a big question, probably not that fair. I wanted to ask about the changing profile of use of those people needing this service, because my understanding is that, you know, around sort of need is augmenting. There are higher levels of need, and what does temporary mean? What should we understand by temporary? And I wanted to ask also about assurances that this tender will deal with lessons learned in the past. So those would be my basic questions. Thank you.
Guy, to sum up, please, or to answer.
Hi, yeah. Noted regarding the inequality across the county, as you say, I won't go into that, but this is a starting point for us. So we wanted to make sure that we were including provision in East Cambs and in Fenland. And as we understand in greater detail what the need is, because we have been challenged in getting some factual data to build the need, then we can work on that throughout the life of this contract so it can develop and evolve. So I fully take that on board. The broader provision, workforce is always a challenge. And if we're looking at the new areas, it could still be a challenge, but it's something that we need to obviously work towards. Whoever the successful bidder is for this tender, it's been clearly stated, it will be clearly stated within the tender information about the expansion of the service into those areas. And I have to say, whilst there have been challenges with the current provider in terms of workforce, they have managed to continue to recruit and retain staff within this service, not without the challenges that there are within care recruitment more broadly, but they have managed to do so. That links obviously to the provider market as well. Changing profile of use, yes, absolutely. There is a changing profile of an emerging profile of people that are more complex, linked into co-occurring conditions, which is drug and alcohol, etc. So what I didn't go through, obviously, with in my preamble was some of the areas and development. Hopefully that's been covered to a degree in the paper, but I'm happy to have a conversation if people want a more in-depth. I can go on for hours about this, but yeah, we can absolutely do that. And in terms of lessons learned from either previous situations or etc. Yes, absolutely, that's been built into the quality questions and the lessons learned from that, and also within the specification of the contract. I think that covered it all. I'm not quite sure.
No, thank you very, very much. The recommendations are to approve the recommissioning of the accommodation-based supported living service for people with moderate to severe mental health needs in Cambridgeshire on a 3-year basis from the 1st of July next year, with an option for a 2-year extension periods costing £1.2 million annually, total of £8.5 million over the total term of the contract, and extensive extension periods, and delegate approval of the award and extension periods to the Executive Director of People and Communities. Anyone want to vote on this? Could you nod at me if you agree? Yeah, and I'm seeing that all around the table. Councillor Howell this time also nodded, which I was very pleased about. Thank you very much indeed. And in response to Councillor Van der Ven's point, just to inform the committee, these issues about the provider market, how it's doing and what we do about it, is going to be subject not just in this area, but across the piece in a report that Will Patton and his team are going to do for us in March. And that's going to be a very major discussion that we're going to have in March, just to highlight that to you. We now move to item 10, adult social care self-assessment. It's pages 159 to 202 of the agenda pack. And Debbie McQuaid, Assistant Director of Adults and Safeguarding, will present the report.
Thank you. So the report provides an overview of the Council's self-assessment. The self-assessment is a core part of the Eastern Region sector-led improvement. The self-assessment covers a wide range of themes, and within the report you'll see we've highlighted our top achievements as well as our biggest challenges. The self-assessment gets submitted every year, so it was submitted in March 22. We then had external challenge in July from an ex-DAS. That's the Director of Social Services, Adult Social Services. And then we attended a regional event in September that we attend with the Eastern Region. One thing I will say with the self-assessment is there is a lot of variation, and that variation is sometimes based on, we've always completed our self-assessment based on the previous 12 months. And what we found at these, what some of the other local authorities have done, have based it on, you know, looking forward. So we have agreed that we need, you know, in order to make those comparisons, we're all, you know, we all have to be focused on the previous or the next 12 months. So that's a further piece of work we need to do. We're also in the process, so although we do this annually, we are now completing a further self-assessment, and that's based on what I'm still going to call the draft CQC assurance framework, but we have got a fairly good idea of what that will look like. And we've got external challenge planned for February. The reason, again, the Eastern Region are keen to do this is because with the introduction of the CQC assurance from April 23, and adults not going through that regime for many, many years, we want to be in the best possible position to be able to, you know, present the council in a really positive light. So in preparation for the CQC assurance, we also invited the LGA to undertake a peer review, and that built on the self-assessment. We received a lot of positive feedback, but within the report, we've focused on the areas that require further development and the actions we've taken to date and how we intend to take that forward. And then to supplement both the internal and external challenges, we've worked with the Adult Social Care Forum and the partnership boards to identify our stakeholder priorities. And again, the paper summarised the findings from the activities under the headings you said and we did. What you will find in the paper is that there are reference to the social care reforms, because at the time of self-assessment and the peer review, our expectation was that the reforms would be implemented in their totality. As we know, some of the reforms have been delayed, and we're still not sure at this stage what sections of the reforms will take forward, will be taken forward apart from the assurance framework.
Thank you very much. A really important item, this, in terms of the quality of what we do, the external scrutiny of what we do. And in a way, we are a bit like a school awaiting an Ofsted. So we must take this really, really seriously. Councillor Daunton is first.
Yes, thank you. Because this is a public report, I just wanted some clarity on some of the terminology used. So mainly in the section 2.3, vision and co-production. You talk about the adults positive challenge. I'd just like a little bit more information about what exactly that means. Again, we have the phrase co-production, what exactly that means. Think local, act personal, and then changing the conversation. So this is all terminology which I think probably means a lot to people within the profession, but perhaps not to the general public, and perhaps not also even to some of us. Thank you.
Co-production is absolutely embedded in the social work profession at the moment, isn't it? So we're not going to shift that one. And didn't we have an item on it only recently at this committee? Next one is Councillor Bowden.
Thank you, Chair. Two items. The first is paragraph 2.5.4, which very much interested me, which is the tech first approach, the technology enabled care first approach, which we are told is now well embedded in practice. And of course, we have just had an agenda item where we talked about 110,000 of additional investment, part of which is to do with tech to produce savings. As I've already said, I'm a very great proponent of tech where it's possible to utilize it. And I know that we haven't been at the forefront, at the cutting edge of that, but then you don't always need to be at the cutting edge of developments. My question is, though, on the tech first offer being well embedded in practice, is are there the resources available so that all those who can benefit from tech actually have access to tech? And my concern is that this may be limited in terms of just what resources being put into tech. Now, we have already talked about an additional amount coming in, as we've just said, in the budget for next year. But I was under the impression that there were still some resource implications as far as this is concerned. So if that capacity has now been met, I'd be very interested to hear that. Oh, that was the first point. The second point, I think it needs to be mentioned, this concern that there was, or there has been for some period, a lack of complete management oversight on the safeguarding process. And I think it's really important that we have assurance that that has been fully addressed. Thank you, Chair.
Thank you. I'm for the appropriate use of tech, and I think we are good on it, but I'm for people first. I'm not sure tech first is the right phrase to use, because I think people first and then appropriate use of tech. That's just a personal viewpoint. We now move to Councillor Wilson.
Thank you, Chair. And two points. One, I may be mistaken about this, but the majority of comments where it says you said we did, the you did seems to be we produced another strategy or we produced another plan rather than we actually improved our local services. That may or not be fair, but I'd be grateful for a comment on that. The second, I get very excited by numbers, but I got very confused by those on page 185 with the framework results. And I think the key thing to look at, but correct me if I'm wrong, is that there seem to be an awful lot of KPI equivalents where we are worse than averages across England or averages across the east of England. And also the service seems to have deteriorated over recent years. That certainly doesn't apply to everyone, but on a number of them, it does apply. And I'd be grateful if somebody either in this item or when we get to KPIs later could provide a bit more information about that, please. Thank you.
Anyone else? Personal contribution. Firstly, I very much learned from the ADAS conference that the best way to approach the CQC process is to be honest about shortfalls, but then show that you've got a plan to address them. And certainly the Vice Chair and myself, in talking to our senior officers, have said, please be honest about shortfalls. And so that's why you see that in this report. And it is the right approach. I just commend to everyone. And this direction of travel towards what I'd call localization, personalization, what they call co-production, it very much confirms this is the right direction. This is the best practice. This is what the CQC will be looking for, but it's also right for our service users. And so we're heading in the right direction as far as that is concerned. I share Councillor Bowden's concern. The areas which I most worry about reading this report, as he said, the lack of management access to information about safeguarding is a key area. Secondly, the fact we're just not funding the voluntary and community sector enough on prevention for what we say we're doing, and there are too many travel agents, not enough holidays, is a brilliant challenge. It's a brilliant challenge to us. The backlog on deprivation of liberty is very, very worrying as well. And on equality, diversity and inclusion, we're doing really well, or pretty good anyway, vis-a-vis our staff, but we're not able to evidence it in terms of our services. That's a really important challenge to us. So those are the four that I'd pull out, but welcome they're in the report and welcome the work that's doing. Let me be very, very clear about that. The only other point I'd make is on 2.5.5. Our aim is not to reduce and prevent the provision of social care. Our aim is to provide social care to people who need it, but within a context where if people's needs can better be met by other means, including stopping demand through prevention, then that's part of our strategy. But I really am not comfortable with reading sentences in reports that say our aim is to prevent and reduce social care. Our aim is to provide social care and to provide it to a high quality, but within that broader context. And we changed the strategy paper that's going to Strategy and Resources Committee tomorrow specifically on that point. And I hope that can be heard by officers in terms of future reports. And finally, like Councillor Wilson, when I read you said it's all about we set up a working party or we drew up a checklist. It's not about how the services change. And you know, I really think that by the time we get to CQC, all the answers on that should be about how our services have changed, not how we've gone through some structural process of officers getting together in rooms or on computers to say that they've looked at it. I think Councillor Wilson makes exactly the right point there. Debbie.
Okay, so in terms of the Adults Positive Challenge, that was a 3-year transformation programme, and we have brought several reports to committee. So that was really, again, how we changed the way we work and, you know, in terms of people accessing social services. So that was a real focus on early intervention and prevention. It was a focus on our practice. It was a focus on technology, using re-ablement, etc. So I'm more than happy to provide some more detail on that if that would be helpful. But it is something that, as I say, has come to committee on a couple of occasions. It was and picking up on changing the conversation, that was ensuring that our practitioners were not just focusing on you know, people's needs, but it was also focusing on people's strengths. So, you know, when you're having those conversations with people, it's really positive to have a conversation about what people are able to do for themselves, as well as understanding what their presenting needs are. So that was all part of the Adults Positive Challenge. In terms of co-production is very well embedded with our frontline social workers, our practitioners. So, you know, whenever they're out working with individuals, whether it's an assessment, a care and support plan or a review, it is co-produced with that individual, because ultimately that assessment, care and support plan or the review belongs to that individual. So that's what we mean by that real sort of co-production with individuals. But equally, we know that we need to do more. So when we talk about care together, and that was presented earlier, so that is really finding out about what our local citizens want from the services that we are going to commission. And it's clear they want a more localised provision. So, and also I think we did a training session with the Sun Network for committee around co-production. But again, more than happy to share that information again. Think local, act personal. That's another way of saying, you know, local personalised care. So I'll take on board the comments around that. But TLAP is something that's used by, so that's what TLAP is. Think local, act personal. That's what local authorities across the country have adopted. But I can understand that actually, for public and for committee members, that may not be obvious in terms of what we're trying to illustrate. In terms of Tech First and the investment, the £110,000 investment. So just to say, Tech First and technology enabled care is very well embedded with you know, we've got a tech team, but also it's also embedded with our frontline practitioners. The investment that we talked about earlier is really an investment in additional practitioners, so that actually once people get discharged from hospital, so I'm sorry if that wasn't clear in the previous paper. So it's about, we then focus on re-ablement and technology enabled care, which we may not for people that are presenting with higher needs on that initial discharge. So it's about, you know, how we bolster our workforce to focus on that. Sorry, Councillor Bowden, do you want me to stop because you're looking confused?
Thank you, Chair. Apologies, I haven't been able quite to get to the right place in the agenda on this, but my recollection of the paper was that the £110,000 investment was a one-off and that we were going to get a £310,000 recurrent saving from that. And what we've just been told, it doesn't sound like a one-off, it sounds like a change to complement of staff, which would be a recurrent cost. That's why I assumed that we were talking about tech rather than about staffing.
Yes, yeah, and if, you know, so if we do need that recurrent staffing, then we will that will be built into the budget next year. But for this year, it is, so currently it's a one-off, but it is about staffing. It's not because we've got the reablement, we've got the tech, it is about staffing so that we can go out and review those individuals 6 weeks post-discharge, and that we can think about, you know, whether they're then suitable to go through reablement and to go through tech and any other, you know, universal services that may be available.
Okay, it sounds like it's recurrent. I think a fair point's been made by Councillor Bowden. If that could just be checked for the budget, on the budget issue, as that comes forward.
Okay, so moving on to safeguarding, this was more around the fact that we didn't, so throughout the last 12 months, we've been having our business intelligence have been building our reports for us, so we call them our dashboards. So what we didn't have readily available was a dashboard around safeguarding, so we couldn't evidence that, you know, how we'd been monitoring through a robust business intelligence process. But in terms of management oversight, so, you know, through the heads of service and team manager, there has been that robust oversight. We just didn't have the data and the information to be able to share and present. You'll be pleased to know the safeguarding business intelligence dashboard went live last week. So we do now have that, but we've been through a process over the last 12 months of having all of our dashboards for adult social care in terms of our key performance indicators. They've been rebuilt. I think in terms of the voluntary sector and community sector, absolutely, and we've taken that on board in terms of the longer term funding. And again, you know, we've as Will said earlier, we've received some additional funding for winter pressures, which is welcome because all funding is. And we are looking at how we can use that funding again with the voluntary sector, but recognising that actually that funding has to be long term in order for that to be sustainable. We're also doing some work with our ICB colleagues because we commission the voluntary sector, the ICB commission the voluntary sector, and we need to look at how we bring all of that together. And there are proposals to set up a voluntary sector alliance, so we're hoping that we can address some of this. The DOLS backlog, the deprivation of liberty safeguards backlog, is an issue that's worrying all of us. We are engaging with an external agency in terms of how they might be able to support us, but the backlog is quite significant and it will come at quite a high cost, but it's something we're looking at the moment. We're not alone, so most of the big shire authorities have a similar backlog. In fact, many have got a higher backlog than we have, but that's not, you know, we can't be complacent with that. It's still something we need to focus on. In terms of the dashboard, absolutely, there are some areas that the council we're doing particularly well. Other areas we know we need to improve, and that's all in our development plan. So again, except you know, and some of those changes are very tiny percentages, and I'm not saying that that's not important, because of course it is. But then when you look at the overall, it just seems that we're sort of going in the wrong direction. So, you know, we're looking at all of that, and we've got plans to address that through the development work that we're actually doing. Have I covered? Because there was quite a lot of questions. I'm not sure if I.
There were a lot. I think I'm going to move us on in any case, and thank you for the range of answers that you gave there. Thank you very much. The recommendations are that we note the findings of self-assessment and adult social care national outcomes metrics for 21-22. We note the key recommendations from the LGA peer review. We know the co-produced, you said we did work undertaking in 21-22, and the further planned visioning and co-production development. It's for noting, so no vote is required. Thank you to Debbie. I've taken advice on my left. What I plan to do to try and keep us to time is to take the finance monitoring report next. The safeguarding report and the KPIs can probably be noted fairly
quickly, if that's members' desire. The risk register could be postponed to March if we find we're running out of time. I'm going to tell, does anyone object to any of that? No.
Sorry, Chair, I could just cover the risk register very briefly.
Okay, we'll just see how we do on time. But we are going to take the finance monitoring report next. Justine Hartley again, please. 255 to 300.
Thank you, Chair. Okay, I will be as succinct as I possibly can. The overall position for adults and including commissioning is set out on page 257. So you can see we are combined across adults and safeguarding commissioning under a forecast underspend at the moment of 400,000, and on public health 261. Just to bring out a couple of points that are sort of slightly masked within those total figures almost. So as we have been all year, we are continuing to see pressures on mental health and on physical disability budgets. And those have been offset and continue to be offset by underspends on the older people's budget. And that's because we've not seen older people's budgets grow in line with the level of demographic growth we had built into the business plan for the current financial year. We've addressed that for the business plan for next year. Our demographic growth for older people is done on a completely different basis. But we are continuing to see that, and that is keeping us overall within budget for the year to date, which is good news. And the other thing that is in here and that we talked about at the last committee, but is within the savings tracker in this report, we talked last time about the learning disability partnership and the split of costs between ourselves and health partners. We had built into the business plan an increase in the contribution from health. We are still working through that very hard, but the likelihood of that being implemented in this financial year, as we're now already in December, obviously, is fading somewhat. So we have assumed, for the purpose of this report, that we won't get it this year, although we talked last time about backdating, and that option will definitely be pursued. So you are seeing that within the strategic management adults line, which has pushed that up quite significantly. But as I say, it's all sort of accommodated within the bottom line figures. So we are still forecasting an overall underspend for adults and safeguarding and commissioning combined. The other thing I just wanted to say really quickly was the finance monitoring report itself was published for Children's Committee, obviously some time back. I didn't want to change the actual report because it's been published. So the covering report talks about adult social care reform, the fact it's been delayed now, which wasn't reflected in the actual finance monitoring report. So obviously when you see the November report, that will all have been updated. But obviously, as you know, we've done a lot of work on cost of care. We had some money from government for moving towards the cost of care output from that exercise for this financial year. We expect that to continue next year, but we don't expect to get any more. The provisional local government finance settlement we're expecting in the early part of next week. So that will confirm those numbers for us. But as Councillor Howard referred to earlier, that exercise has created an expectation, and without the funding, we will have extreme difficulty moving towards closing that gap between what the outputs of the cost of care exercise said and what we pay to providers. And I think that's all I wanted to say, but happy to take any questions.
Questions or contributions? Councillor Sweater.
I wonder if I'm concerned how things would fit together in this council, obviously, and I'm wondering the elephant in the room might be this, and I'm wondering in what way different departments of our council are contributing to the survey in terms of the costs of transport, cost of caregiving, all these sort of things need to be worked in and worked out.
Just to help people watching online and people with poor eyesight, could you refer to which survey?
Yeah. Oh, sorry. Yes, this is the brochure. I'm sure we all know this one inside out. The Making Connections and Sustainable Transport, because this has come in here, there and everywhere today. And I am really concerned to know whether people who are making the big decisions and trying to do the hard sums are able to feed in how the people working
to deliver our care will fit into a system of road pricing in whatever form it comes or whatever. So we want to make sure that you're in the system as, as contributors to the consultation. That was my question. Well, sorry about the visual aid.
That's a big question. I'll get Charlotte to answer it because I think it covers across the authority. I'll just see if I've got anyone else first, if I may. No, I haven't. Charlotte.
My understanding is that as part of that work, we are having discussions about care workers who have to go across the city and whether they could be treated differently. So that's not been agreed yet, but that's the conversation.
You're in the system. Thank you.
And Justine, I think as that was the only contribution, there's nothing to add. Are you happy? Okay, thank you very much, as ever. And the recommendation is that we review and comment, as we have on the relevant sections of the People Services and Public Health Finance Monitoring Report as of the end of October 22. So there is no vote required. I now move to, I jumped one, so I'm now going to go back to safeguarding annual report. And I think Charlotte can briefly, right, in what order? Donna first. So yeah, hello Donna, welcome to the committee. Sorry that it's a bit pressed for time, and if you can make a very concise presentation, but then obviously we'll see what questions come.
Yeah, thank you. Good to be here. So I'm Donna Glover. I'm Assistant Director for Adult Social Care in Cambridgeshire, for those who I haven't met yet in person. So I'm here today on behalf of the Safeguarding Adults Partnership Board. My colleague Jo Proctor, who's on leave, would usually present this. So I lead on adult safeguarding in the local authority, but it's really important to point out this report is across the partnership board. So it represents the work and the oversight that that board have across multiple agencies. So that would include our health colleagues, police.
We're not hearing you brilliantly. If you just bring the microphone
a bit.
Or bring the microphone closer to your mouth is probably the
easier
thing to do.
The camera as well.
Happy? Yeah, go.
Can you hear me now? Okay.
It's me.
Great. Thank you. So I was just saying that the report is about the partnership board in the round. So it's not just a local authority report. I lead on safeguarding in the local authority. I'll focus briefly on the parts that are most relevant, I think, to the local authority, and I'll be very quick. So it has been a year of change again during the period that this report covers, obviously, as we've been moving in and out of different COVID situations. So it's been an interesting reporting period in terms of activity and safeguarding. And if I could maybe just refer back to the previous point about oversight of safeguarding, we have had some challenges around seeing what our activity is on sort of business intelligence dashboards, etc. But we've got some brilliant staff who had the foresight to maintain lots of really good manual records. So we have always had an oversight of the activity, just not with the sophistication that we would have wanted to have seen, but we have got that now, as Debbie said. There have been a number of sort of ups and downs in the numbers. So some of that reflects work that we do with other agencies. So ebbs and flows in the number of concerns that we see. We've done a lot of work with partner agencies to understand when things should come through to us as a safeguarding concern and when they're better placed elsewhere. So that's a positive thing, but sometimes shows us a reduction in some of the safeguarding concerns that we have coming in. We have constantly striven for improvement in practice, and some of that's reflected in the report and continues. Very keen that there's transparency around that and a plan, as you alluded to earlier, Councillor Howard, when we identify where there are things we could improve, that we've got a plan to show how we're going to do that. We're extremely fortunate to have a very strong multi-agency safeguarding hub who take all inquiries for adults where concerns are expressed for safeguarding and triage those. They're very strong, and in a recent external assurance exercise, we're complimented on that. I'm really keen to take forward the work in the coming year to strengthen the actions in safeguarding adult reviews. I think that's a really important piece of work. it can sometimes feel that small actions are given to each individual agency, and sometimes there are some big systemic things that we need to tackle. And I think the safeguarding adult review subgroup are really starting to get into the bones of those. So I'm looking forward to coming back next year and telling you a bit more about how we've done that work. We participate fully in all safeguarding adult reviews. Our services refer those in as well as other services, and we'll continue to do so. I'll stop there, conscious of time.
Thank you very much. But Councillor Bowden, please.
Thank you very much indeed, Chair. Very, very important area, of course. Now, I'm aware of the large amount of work which is put in on safeguarding, and justifiably and necessarily so. What I'm interested in, and what I've not managed to ascertain, not just from this paper, but previously, is the way in which we manage risk within safeguarding. Now, our general risk register doesn't really apply when it comes to a lot of the safeguarding work which is done, because our general risk register is based on, it's a very, very common way of doing it. It's a very easy way of doing it, I have to say. It's based on looking at the likelihood of something happening and the effect of it. And the likelihood is measured from 1 to 5, the effect from 1 to 5, and you multiply the two together to get to a supposed risk calculation for that particular item. And for us, if the total number is less than 16, then it's within our risk appetite. But that just doesn't work for a lot of safeguarding, where some of the never events, which should never take place within safeguarding, they may well have a likelihood of 1, but that still isn't sufficiently. It's not sufficiently granular, nor could it ever manage to exceed our risk threshold. Because for our risk threshold to be exceeded, either we have to have a likelihood of at least 4. Well, we have to have a likelihood of at least 4, or an effective at least 4. And we have to have both, in fact, or 3 and 5. So with a likelihood of 2 or 1, we never reach our risk threshold looking at our general risk register. So my interest is, how is risk measured in safeguarding, given that our general risk register isn't a risk approach isn't a correct way of doing it? I'm quite confident it's done. But the granularity of risk which is involved, and the fact that you have never events within safeguarding, means that it must be done in a different way from what we generally see. And I don't think that's ever really come before this committee. Thank you, Chair.
Thank you. Anyone else? Councillor Howell, please.
Yes, thank you. Very quickly. I notice where you break it down to Cambridgeshire and Peterborough, the different types. Can I ask, is that a fair assessment of the country and the percentages? I appreciate there might be some more either side. And equally, I'm surprised with regards to the, you say there the majority of risks are located in their own home, followed by residential care homes. That's quite disturbing. I wonder if you'd like to just make a small comment upon that, please. Thank you, Chairman.
Thank you. A couple of comments from me. One is this is one of the areas that I entertain personally, attending meetings of the Safeguarding Board, and I honestly commend the quality of work that takes place, and I think it's outstanding. And we as an authority contribute to that. I've got the highest praise since I've got involved in doing this. And so, secondly, thank you to you, Donna, for what you said about recommendation B. I think we can do better as an authority, and I'm really pleased to hear the commitment of the officers to undertake that work. Donna Cover.
Thank you. Councillor Bowden, you raised a brilliant question. I think we could probably talk all afternoon about how we manage risk in safeguarding. I think there are lots of strands to the answer. So there will always be a risk around safeguarding for the local authority. There will always be a risk that somebody with care and support needs suffers really unfortunate outcomes, and we were aware of some of the risk, and with the benefit of hindsight could have acted differently. So that will be an ongoing risk, and if you like, we'll all sit with us on a risk register or otherwise. I think there's then a question of how we've got governance around our safeguarding activity, and obviously the boards are part of that. The reporting that we talked about earlier is part of that, so we need to be benchmarking against other areas. But in terms of risk at that granular level, we have a triage system. So I mentioned the multi-agency safeguarding hub, the MASH. It is a real strength of ours because it's a single team that triage all inquiries. So they have the benefit of seeing everything that comes through. And as soon as a concern comes in, I can tell you it takes, I looked at the dashboard early this morning, 0.1 of a day to look at it. If even further initial inquiries are needed, those are generally completed within 1 or 2 days. And then there may be a further safeguarding inquiry that's undertaken. It's referred to as a Section 42 inquiry in this report. At that point that the concern comes in, we have a triage system that allocates it as immediate. So we need to do something now because there is a risk that appears to be very present and needs mitigating quickly, high, medium or low. So there's a triage point at the point of each individual concern coming through. So I think threefold is the answer: the governance, the individual triage, but also that ongoing risk that we carry because we have that statutory responsibility. If you are interested in that individual triage, the MASH team are based in Manchester. If you've not been there, they would be really happy to meet you. They're a great team, and they can sort of talk through that granular level of triage that they do. Just in terms of your question about sort of percentages and, you know, what that looks like, Cambridgeshire, Peterborough, obviously slightly different. We take a really close look at those numbers and look at how we compare regionally and also nationally. So at the moment, I'm really interested in our conversion rate. So by that, I mean the concerns that come in and then how many go to those Section 42 inquiries and whether we've got that quite right. So we're testing our decision making at the moment because we look a little bit lower than some areas. And we're exploring at the moment the opportunity to have some external input around that to test it even further. So the answer is we're in the ballpark, but where we do see slight variations, then we look to test what that means in our practice. On the point about people's own homes and care homes, in a way we see things where they can be seen. So in terms of care homes, there are a lot of staff in and out of care homes, etc. So in a way, things are more likely to be picked up. And of course, they're a setting where you've got a concentrated group of people who may not be able to advocate for themselves, have high levels of care and support needs. So in a way, it's inevitable that you'll see more reporting. But we monitor very carefully the concerns that come through from care homes. I have a fortnightly check-in with teams who have involvement in this, including the MASH, and we pick up any themes that we're seeing that we need to take further action on where we start to have concern about particular settings.
Thank you very much indeed. The recommendations are to receive and note the contents of the 21-22 annual report and to recommend that work is undertaken by adult social care officers on how transparency and accountability can further be improved in safeguarding case reviews, not simply in promoting organisational learning and seeking to prevent recurrences in relation to failings identified, but also in seeking for the County Council to provide clear and timely acceptance of its responsibilities to relatives for any failings, including apologies where appropriate. Any recommendations will be further shared with partners in the Safeguarding Board for their consideration. Anyone want to vote on this? No? Could you nod at me if you agree? Yes, again, I'm seeing consensus all around the table. That is agreed. I know I'm dotting around, but I'm trying to get through everything. If anyone wants to speak, it's your right to do so. That won't be stopped. I'm going to do the KPIs report next, and with the permission of the committee, this is item 14, pages 301 to 328. Val Thomas and Debbie McQuaid are here. Can I suggest that we take the report as read and just take any questions? If anyone objects to that, I'm absolutely open to it. No, that looks fine. Any questions or comments on the KPIs report? Or we could just note it. Yes, we'll just note it. One question. Councillor Wilson.
I'm happy to note it, and I'm pleased to see things clearly marked improving or declining. But what we don't have in this report, which we had in the earlier peer review challenge report, where we had the framework showing how we compared with East of England and the rest of England. It would be interesting to do that at some stage for the very key performance indicators, not obviously for everything.
That can go in the minutes, if please, Tamar. And if anyone else? In which case, I'm going to ask for the report to be noted with thanks. I'm now just going to take committee members' guidance. We could do the risk register quickly, or we can defer it to March. Anyone got any strong feelings? Quickly, I'm hearing. Okay, Charlotte Black, please.
Certainly. Can everyone hear me okay? Yeah. So hopefully you'll see in this risk report the kind of risks that you hear about regularly at the committee in the form of various different reports and papers. So there shouldn't be any surprises in here. What it's really doing is pulling all that together in one place and kind of quantifying those risks. So as section 2.5 of the report sets out, it won't be any surprise that the main risks that we think exist for this, particularly for adults, are obviously financial pressures, provider sustainability, increase in demand as winter sets in, recruitment and retention of staff, and our ability to respond to the national reforms in adult social care. So very happy to take any questions. I would be really concerned if, as a committee, there was anything in here that you felt you weren't aware of or wasn't familiar to you. But I think some of you have got lots of expertise in risk registers, and I think there's always probably issues around how we score things and making sure that's as precise as possible. But just to reassure you that we do regularly review these risks and the scores, and going forward, because there won't be a people directorate anymore, there will just be an adult social care risk register, but that will also need to include commissioning for adults.
Thank you. Questions, comments, please. Councillor Bowden.
Just a very simple one, very similar to the comment I made previously. Would it be accepted that stating that our risk appetite is 16, as is stated in the report, is, on the matrix, is a slight oversimplification, in that there are some areas where the likelihood may be very low, but nevertheless our risk appetite is not going to, if it's the likelihood's very low, the risk will never come to the number 16, but nevertheless we do have a risk appetite, and that risk appetite is quite low.
Anyone else? The only thing, oh yes, please, Councillor Howell.
Yeah, thank you. This might be more of a conversation than a question, so I'm happy for you to say to take it outside the committee. You say here with regards to high-profile cases arising from safeguarding adults at the risk of abuse or neglect, and I know what you mean, the reputational damage and one thing like that. Taking back many years ago, the case which I suppose is on everybody's mind from many years ago, which was the Ricky Neve. Do you think that there is a time period where that is then gone and then we can move on, or do you think that's always going to hang over our head?
That's another really big question, isn't it? Anybody else? The only point I'd want to add is I think the most important column is the one on the right-hand side, which is what we're doing to analyse, mitigate and control the risk, and we're reliant on lots of people, both within our service and amongst our partners, to insist in doing so. But this, I think I'd agree with everyone that this is really important, but all of the risks are top of our mind, and there isn't anything new in answer to what Charlotte says. Charlotte.
Thank you. In terms of the sort of technicalities of the risk register and what's a low or high risk, I mean, certainly we obviously have to operate within the corporate sort of risk management process, but we'll certainly take that comment back. Because I do sometimes think it feels more like an art than a science in terms of quantifying risk. I think that's the reality. And Councillor Howell, your question about serious cases, I think they do stay for a long time, and in many ways they sort of should, because there's so much to learn from them. There are many equivalents of the Ricky Neve case, probably less high profile in adults, but I think we are very committed to learning from them and making sure we don't forget about them. But it is also really important that you know, often that involves, you know, particular frontline workers and teams who it also hangs over them. And I think we're very keen within adult social care to have a culture of kind of learning and supporting our staff to do things better and differently going forward, as Donna said, whilst not tolerating things that aren't good enough. So that's often a difficult balance to strike, especially if people feel personally responsible. So it's a good question, but a difficult one to answer.
But in the end, you can't bring it down to numbers of people, and it's about judgment and the professional judgment of all in our service. Are people happy with the recommendations which I need to read out and which are to review and comment as we have on the relevant sections of the People Services and Public? No, that's not the one. I apologise. Sorry, I need to go to the. Sorry about this, folks. Got it. Which is the recommended to note the adults and public health risk registers, no vote required. Are people happy to note the item 15, the committee and agenda and training plan? And if people want to make additional suggestions, come to myself or the vice chair, and we'll happily listen to them outside the formal part of the meeting. Are people happy with that? In which case, thank you everyone, for particularly the officers this morning. I think have been really good in their presentation. Thank you very, very much. We've had some really good debates. We do deserve some time off, and we'll be back here at 2 p.m, please, for the afternoon session. And we've hit 2 o'clock. Welcome to Jenny Gilthrop from Cambridge City Council who's joined us. Do we have anyone online that's joined us remotely? And Councillor McAdam is here. Thank you so much. Thank you. Hey, Mark. Okay, Councillor Garvey from South Cambridgeshire is joining us online. I think, is there anyone else who's joining us that I haven't introduced? No, that's fine. Usual chair's introduction. We allow filming and photography. Feel free to take pictures and use social media, but make sure your mobile phone is on silent, and that is subject to not disrupting the meeting in any way. Please be aware this meeting is being live streamed and the recording of the meeting will be available on the County Council's website. Two additional points. The first one, and this has been discussed with the council, but we've received this feedback that the scrutiny sessions we're just trying to do too much and there isn't enough time for questioners to come back, because we do it in one long round of questions and one long round of answers. So we've cut it down to 2 items this afternoon as an experiment, and I'm going to do it in rounds of questions and answers to hopefully enable more interactivity. We'll see how it goes and then we'll review it afterwards, and that the Conservative group have encouraged me to use chair's discretion, so I will do, and I hope they'll support it when I say they can't speak again, but I will genuinely, without any political bias, as always, just try to use discretion on all of that. And so if people can just be aware of that and feedback afterwards, whether it's worked or not, and any other tweaking that we can do to make the scrutiny sessions even more productive. Secondly, it's the RCN strike today, and the chief nurse was going to be present for the item that on the Learning Disability Summit, and in line with the RCN's position, she won't be attending and it's not appropriate for substitutes. So I think we just have to respect that. I don't think it's appropriate for me on the authority, on behalf of the authority, to say anything about the strike. But I do note the fact that the General Secretary of the RCN today has said that it's a tragedy, that she apologises for the disruption. And I think we all hope that there will be a successful conclusion to issues around fair pay, terms and conditions for nurses. I think that's not controversial for me, for me to say that on behalf of the authority. And Charlotte has kindly stepped in and will introduce that item when we come. And it does open up a little space when we do the forward plan to have a bit of a chat between ourselves about what are the priorities for future scrutiny. And so can you be thinking about that? And when we get to that item, I'll be asking, we won't just note the report, we'll just get suggestions from members about areas that you would like us to focus on for scrutiny. So if you can just be thinking about that before we get to that item on the agenda. So those are my chair's announcements at the beginning of the health scrutiny section of this meeting. We now move to the first item, where Cambridgeshire South Care Partnership, ICP, have kindly come along and presented a report to us, which is at pages 353 to 362 of the agenda document pack. We have the North Care Partnership before, and so we're really grateful for the South Care Partnership to be here. We've got Erin Lilly, who's the Director of ICP Development and Transformation for the partnership, and James Morrow, who's the Managing Partner at Granta Medical Practices. Thank you both for being here. And the ICP is very new for all of us, but for us too. And so we're very, very interested to see the latest developments and your perspectives in our work together, but also in reporting to the public, which this scrutiny session is an element of doing.
So Erin and James, welcome to the meeting. I don't know who's going to go first. Erin.
Brilliant. Thank you for having us. So I'm going to do a little bit of an intro to what we are as a partnership and some of the work we've been doing with council colleagues, and then and a little bit about challenges and opportunities, and then I'll hand over to James, but just to pull a few highlights out of the paper. So across Cambridge City, East and South Cambridgeshire, organisations that provide support and care and healthcare are working together as Cambridgeshire South Care Partnership. I think we have finally settled on that name, to better understand the needs and ambitions of our approximately 440,000 people living in our communities. As a partnership, we did some work to agree on a fairly ambitious vision, with the challenge of keeping it at bumper sticker level so we can all repeat it. And so that is around people living in Cambridgeshire South enjoying healthy lives in strong connected communities. We're sort of in a new, almost startup phase of the next stage of the work, I guess. So we're developing new ways of working and collaborating across our combined resources. And by that, I mean staff, buildings, funding, all our resources, to deliver more joined up care so that the people living and working in our neighbourhoods experience the health and wellbeing outcomes that matter to them. That's a key part of it. We know that in the south part of Cambridgeshire, many of our people enjoy better than average outcomes in life and in health, but we also know that some people experience considerably worse outcomes. We know Cambridge City's the most unequal city in the country, with big gaps in life expectancy of about 10 years. And you'll have no doubt heard from other council colleagues around moving the conversation to talking more about the quality of those life years, not just the how many years we have. And we also know that our health outcomes and our life outcomes go far beyond healthcare as the main contributing factor. And of course, we're not aiming for average. We want everyone to have their best life possible, and in line with what their personal ambitions are, not what we determine for them. So as I said, we're moving into the next level of partnership maturity, I guess, and all of this is built on some really fantastic collaboration, particularly over the last few years. Not least through the pandemic, and of course as we go into supporting people around cost of living challenges. You've got some of these summarised in the paper we've shared, but I just wanted to pick out a few examples. So our integrated neighbourhood teams have been engaging with their communities over the last year to improve, for example, confidence in managing diabetes and menopause wellbeing, and the county and district councils were really key partners in these events. And actually, if you attended on the day, you wouldn't have been able to tell the difference between who worked for which organisation, which I think is a good measure of partnership working. We've been partnering with Healthwatch to recruit and develop 12 community champion roles to work with us to undertake peer research within their communities, and particularly focusing around people that we might not hear as much from usually. And so that's been brilliant in itself, but actually as an unintended benefit, I understand that 3 or 4 of those health champions have now used those new skills to gain further employment. And that wasn't really the point of the piece of work, but it's a really nice accidental, I guess, in a way, benefit that is making us think more about how do we actually do that a bit more intentionally rather than pleasant surprise. We've been working with the council teams a lot in terms of leading a pilot across the county to improve experience, timeliness and coordination of discharge processes and pathways. Many of you will know that's been ongoing work for some time now, but we're making